Regulation. That's what we're going to talk about today, specifically cancer. I really break this lecture down into two separate sections. The first section is more generalized content about cancer as a whole. And so when we start breaking down specifics of each type of cancer, go back and think about how we treated cancer in general, the emotional support, the other social services, things like that that we talk about in the generalized cancer section, how the cancer forms, develops, how we stage it, diagnose it, how we grade cancer as a whole, then apply that back to the specifics of each of those cancer types. Okay. All right, what is cellular regulation? It's a big fancy word for basically the balance of our cells within our system. So we have a continuous rapid division of our cells, and each of those cells has a real specific function. So you have your liver cells. They're going to continuously divide and replicate, so your liver can do the things that the liver needs to do. Same with your heart cells. If you have a cervix, the cervix cells. If you have lungs, then your lung cells. So our cellular regulation is that homeostasis, that balance of the division of the cells. Now, when we switch over to cancer is when we lose that process or that balance, that normal cell division. Our body, for some reason or another, whether it's our immune system or some other process, is not able to regulate that rapid cell division. So we have continuous cell growth, and we're not able to control that, and it just becomes overwhelming to our systems. And that's how we have the tumors begin to develop. This is figure 18.1 on page 376. It's the exact same picture. I put all the figures, all the tables, all the things that I'm going to say wise at the very end of the Canvas page. So if you don't get something, it's at the bottom. Okay. On the left, we have just our normal cell. Everything about it is normal, pretty much. All right, it's uniform, it's symmetric. It looks like a nice, healthy cell. We can tell what that cell is for. So if it's from the liver, if it's from the heart, or from the lungs, they like to join together nice and easily and form, so that we continue to have that same symmetrical appearance to it. On the other side, we have the cancer cells. They're these ugly-looking cells, pretty much. We don't really know how to differentiate them. They don't really have a specific task or function or goal. They just know that they need to continue to divide, but they really don't help out with any bodily function whatsoever. They have a tough time grouping together, and then they can also travel past their point of origin. So if they originated within the lungs, then they can move over to somewhere else, say the liver, or maybe they move over to the bone, something like that. Okay? Now, when we talk about normal cells, benign tumor cells, and then we talk about malignant cells, your first two columns here, your normal cells and your benign tumor cells, are going to be very close and very similar in their appearance and in their function. All right, your normal cells, they're going to have relatively slow growth, relatively slow cell division, and they're not going to rapidly grow, say, like our malignant cells. And we know their function, we know their purpose. Same thing with the benign tumor cells, but we're not able to regulate that cell division. So they have this overgrowth within that specific area, say within the lungs. But we still know their function, they know their purpose. They're just causing an excess overgrowth. Benign tumor cell or that non-cancerous cell, that's what we can classify it as. And then we have our malignant cell or our cancer cell. Now we don't know what their function or what their role or what their purpose is within the body. We have that rapid cell division, that continuous cell division, and so they're having this overgrowth. Then they can also move as well to other parts of the body. So that's just another way of breaking down what these cells look like and what their role is. We can classify these types of cancers really based on where they are or where they originate within the body. So we have benign versus malignant cells. This is going to be table 18.4 on page 380. And so here's just some common types. So we have an adenoma. All right, so that's just the epithelial gland. So we have some type of a tumor with on epithelial glands. What about a hepatoma? Anybody know what that is? Liver. Okay, good. So we're looking at that root word, that base word. Hepat means liver. All right. What about a meningioma? On the meninges, good. Neuroma, we got the neuros involved. And then the name changes up just a touch when we move over to the malignant side or the cancerous side. So we have adenocarcinoma, the hepatocarcinoma, neurosarcoma. All right. Really specific on where it originates or develops. That's how we classify these types of cancers, how we get the name from that. Questions about that? Okay. So how do we grade our tumors? How do we diagnose them? How do we know how much treatment we need or which type of intervention we need to pursue? We can grade our tumors, but we can also stage our tumors as well. with grading of our tumors, I can start off with grade X, and then we move all the way up to grade 4. When we get to grade 4, we have really poorly differentiated type cells. Differentiation is going to be that cell process by which the cells are selected for a specific role or specific purpose. So when the cells are first developed or created down deep in the bone marrow, they really don't have a purpose. They're just cells in general. But then eventually they're assigned to a specific part of the body. And that's what we can call that differentiation. So once we start getting to that grade 4, they no longer are able to be told what to do, really. Okay? This is kind of important. I would probably know this one pretty well, and the next slide I would probably know. So, when we're staging our cancers, a really common one is going to be the TN system for staging. TNM. So T is going to say your tumor, what size your tumor is, how big is your tumor. Is it a small tumor, medium size, large size type tumor? The N is going to stand for your lymph nodes. Has our tumor gotten so large that has metastasized and has started to spread to the lymph nodes, really to the surrounding area? It's not going to travel too far, just to the roughly immediate lymph nodes within that area. And then the M stands for metastasis. All right. Has it spread to other parts of the body? So if we originally had cervical cancer, has it now spread to the liver or metastasized to the liver? So now we have cervical cancer within our liver. So this is just an example of using the TNM scale based on breast cancer. So again, the T stands for our tumor size. We have the T1 classification. That's going to be that 0 to 2 centimeter class. So that's going to be that small, and it works its way up. Once we get to T4, that's a pretty big doozy of a tumor. It's super large. It's big. It's going to be real noticeable. A lot of these are not going to be real noticeable until they get some type of scan or some type of biopsy, some type of imaging to see where they're located and their actual size. But once we get to T4, you'll start to notice it without having to do this imaging. Again, N stands for that. Have we spread into the lymph nodes or not yet? Once we get to the N2, the N3, that's when we have significant movement into the lymph nodes, not just into the surrounding lymph nodes, but even further throughout our lymphatic system. Metastasis, the M is pretty simple. Has metastasized or not? All right. M0 has not metastasized. M1, it has. So it's moved to some other type of organ or some area of the body. There you go. I like this slide a lot. Okay. Right. Simple question. A nurse is reviewing the pathology report of a patient recently diagnosed with cancer. The report states T2, N1, M0 staging of a tumor. Based on the TNM classification system, which of the following best describes the patient's cancer stage?
2 to 5 centimeters.
So go back. So T2 is going to be your 2 to 5 centimeters right there. All right. What else we got? M1.
You
can feel a little bit. It has spread a little bit within the lymphatic system, and it was M0, right? M0. Okay. Or B. Everybody like B? I like B as well. So T2 is the 2 to 5 centimeters. It's a moderate size, medium size type tumor. If we had T1, that's going to be the 0 to 2 centimeters, and that would be more of a small type tumor. So that would knock A out. All right. C is going to be greater than 5 centimeters, or that T4, T3 classification. So that would knock C out as well. Everybody got that? Makes sense? Okay. We have a couple different causes of cancer, and when something causes cancer, we're going to call that a carcinogen. For some reason or another, it causes dysfunction within that DNA strand of that cell, and that's what causes that cellular replication, that cell division to not work right, to have some type of error. So we have that aggressive cell division, that aggressive cell growth. Break it down a little bit further. We can have chemical, physical, or viral carcinogens, and it's really going to be based upon the makeup of each of those carcinogens. So the chemical carcinogens itself is going to be the chemical makeup. What is so special about the chemical makeup? That's what's going to make it a chemical carcinogen. Common examples are going to be your asbestos. You got alcohol. You can have arsenic as well. Cigarette smoke is going to be in this one. Then we have our physical carcinogens. So whatever the physical makeup, so it's a little bit different than the chemical makeup itself. That's going to be things like X-rays or UV rays from the sun, the radon or the natural gas. Then we have things like viral carcinogens. Anybody think of a viral carcinogen?
HPV.
HPV, I like it. Big on cervical cancer. Basically all your V's, HIV, your Epstein-Barr virus, hepatitis. All right, so HIV, HPV. You okay, Bella?
Oh, great. Thank you for asking.
All right, so this is the basically the Cancer Research Institution. This is how they're going to classify carcinogens. Your group 4 is a little bit backwards. Group 4 is going to be probably not a carcinogen. And so if they put it in that ranking system, it's most likely doesn't have enough research yet to cause a type of cancer. Okay. Then we go on and we elevate to group 1, where it's definitely going to have some kind of carcinogenic effect on cancer. Okay.
The grades are in, so we're sorry.
That's fine. Something is happening, but I don't care. I'm just going to keep talking.
Just give us a minute to breathe.
Do you want to pause real quick?
Please. Yeah.
Okay, that's fine. Let's go. What are we talking about? Carcinogens. All right.
We have
This-
carcinogen run through the sun.
This picture and this picture are pretty close, similar. It's just another way of looking at it. All right. This one breaks it into a little more detail. I kind of like this one a little bit more because it shows you some different occupations, some different types of carcinogens, gives you some examples from there. Again, like I said, category 1 is going to be your most extensive, your most dangerous. So again, you have your smoke, you have your asbestos, your pollutants, you have your UV sunlight, alcohol. There's hairdresser on there, so if you want to become a hairdresser, those chemicals, a lot of hairspray and perming and stuff causes some stuff. Nursing doesn't work out, you want to become a hairdresser. I'm sure there's something wrong in nacho stands that could be a carcinogen.
The cheese. Well, nursing has those purple wipes.
Who knows?
Yeah.
Yeah, you're supposed to wear gloves with those, but I never do. Anyway. All right, this is table 18.8, page 382 in your book. These are just generalized signs and symptoms of cancer. Nothing super specific. Some may be a little more specific than others to a certain type of cancer. But in general, these are going to be some of your warning signs. Hey, maybe I need to investigate a little bit further. They might have a potential cancer diagnosis on there. Spells out caution. So things like changes in bowel habits. It's either they're going too much or they're not going enough. Usually not going enough. Some type of sore. That could be potential for some type of skin cancer that's not healing all the way. Usually you're going to see weight loss as well. That one's not in here, but that could also contribute to that difficulty swallowing and you're not getting enough adequate nutrition. So some type of unexplained weight loss. Just a nagging cough, hoarseness, that could be an indicator of lung cancer. So just go through these. I would really know the difference between your primary prevention and your secondary prevention strategies. So how could I define primary prevention strategies? What does that mean to me?
Stuff that you can change.
Stuff you can change, that's going to be your modifiable risk factors, but that's within the primary prevention. Avoiding it altogether. Good. I like it. Primary prevention is going to be preventing it before it even occurs. And the number one way to do that is avoiding the carcinogen or whatever is going to cause that cancer. But when you think about primary prevention, we haven't had the disease process at all yet. We're trying to prevent it before it even occurs. Versus your secondary prevention, that's going to be more of your screening tools. So your mammograms, your colonoscopies, sometimes your digital rectal exams. We may already have the disease at this point. So now we're just trying to catch the disease process before it escalates. It gets a little more severe and we're unable to control it. We're trying to treat things early before it gets worse. That's what our secondary prevention strategies are. So we're talking about primary prevention. We got things like your modifiable risk factors. So we could probably quit smoking. We could probably not drink so much. Maybe we should get off the couch every now and then. All right. We can get certain vaccinations. The Gardasil shot, that's an excellent example for your vaccinations. To hopefully prevent HPV, which is going to be one of the number one causes for cervical cancer. We already kind of mentioned some of the secondary strategies, but again, your mammograms, your colonoscopies, any type of screenings, you got your skin checks. Little old ladies will go to the dermatologist and get their whole body checked. Make sure they don't have a melanoma or something. Okay. We're going to go into a little bit further detail on exactly when we go into these screenings, when we get to each type of cancer, but just keep that in the back of your mind. Which of the following is considered a primary prevention strategy for reducing the risk of cancer? Good. B, that's that modifiable risk factor or avoiding that carcinogen. So avoiding tobacco and receiving an HPV vaccine. So it's going to be both primary prevention strategies. All right. Mammograms, yearly colonoscopies, and then monitoring those tumor markers. They're going to be within that secondary prevention strategies. All right. So when a patient gets a cancer diagnosis, it's going to be a pretty big impact on their lives, right? So we're going to need a multitude of different specialties to collaborate their care. And so our patient receives the best care possible. Right? When they first get that cancer diagnosis, they're going to need a lot of emotional support in the beginning. They're not going to want teaching strategies. They're not going to want treatment strategies just yet. They will. But first and foremost, we need to check on their mental status, their mental health. We need to provide that mental health support. And if they need further mental health support, then we can get a psychologist, some type of social work gets involved and knows the resources. Then we can get physical therapy involved, speech therapy, as we go further into our cancer treatment options. And we want to involve that patient to the best of our ability, be able to make informed decisions about their care. But first and foremost, we want that mental health to be taken care of first.
Our insurance is pretty good about covering mental health support.
Not in Alabama, we'll say that.
That's what I was afraid of.
It's getting better. And you got to also think about the access to care. There's a lot of rural areas in the state of Alabama, and they really don't have good quality access to care. And so mental health is a big issue. There's not enough providers around here to meet the demand, even within the Auburn area. There's such a growth within Auburn, but we just don't have enough providers. So think about somewhere like where my wife's from. She's from Butler. They have one red light and they have a Dollar General. That's all they have in the entire county. Okay. Is the mental health support going to be really, really good? Probably not. Okay. But some of the bigger cities, they do have really good support systems. Insurance is a little bit better in certain areas. All right, let's start talking about treatment plans, treatment options itself specifically. Usually what we're going to go for is a combination of different things, some type of combination therapy, whether that be something like chemotherapy with radiation therapy or chemotherapy with surgery. All right, so there's going to be a lot of different options out there. More than likely, like I said, we're going to have some type of combination of therapy. And this is really going to be based off that staging and the grading of the tumor, where the tumor is located, whether more of it's a palliative approach, more of a curative approach, what type of approach are we trying to go for? Are we trying to cure the cancer, or is it so invasive that trying to cure it is going to decrease their quality of life so much that it's not even worth it? All right. So this is your surgical options right here. We have prophylactic. So if they're at a really great risk for it, some patients go ahead and elect to have surgical prophylaxis already. So for instance, if they have the breast cancer gene, the BRCA1 and the BCR2 genes, they may go ahead and just get a double mastectomy and go ahead and get rid of all of it. That way they can prevent them from ever developing breast cancer. Or they can have a hysterectomy. So if they have a strong family or genetic history of cervical cancer, go ahead and get that taken out. Okay. So they don't have the disease process yet, but we're trying to prevent it from ever occurring. That's what your prophylaxis is. Your diagnostic and curative approach, the taking of the biopsy is going to be crucial when we do the surgical approach for this. So if we don't take a biopsy, how do we know if it's cancerous at all? You got a question, Sam?
I do. So for the prophylactic, does it have to be like a certain amount of family members, or is it like, oh, my mom had it, so I want to get the surgery? Or does it have to be like, my mom had it, her mom had it, her mom had it?
That's come between the surgeon, the oncologist, and the family member itself or the patient itself. They're going to make an informed decision together. It's not really an exact, like both family members have it, yep, you're going to have breast cancer. So go ahead and have a mastectomy.
Does the insurance cover that?
Sometimes it will, but it is prophylactic, so it may be tough to get it covered. It's almost like an elective surgery to have a mastectomy. So, but yes, our biopsy, that's what we're going to use. We're going to take a small sample of that tissue, and that's how we're going to confirm there's cancerous cell growth within that area. They can look at it under a microscope and see what kind of cell division we have. Is it the same type of cells that we took a biopsy from? So if we took a biopsy from the liver and we have cells from the cervix, for instance, then we have metastasis that has already occurred. Okay. And then we can also go ahead and just remove it all together. So we have that thyroidectomy where we take out the thyroid. We can take out a part of the lung. So we remove all of those cancer cells and hopefully have a curative surgery from that. Like I said, the palliative side on the far end over here. That's really just to improve that quality of life. This is definitely not curative at all, but maybe it's around a vital organ. So maybe it's around the aorta, and they have some tumor growth around the aorta of the heart. Of course, we may not be able to cut out all of that tumor growth, or we could nick that aorta, and then we could have bigger issues. All right. Or maybe it's causing an obstruction within the large intestine. So we remove most of it so they can have normal bowel function again. It's not curative, though. That's the main thing. Let's talk about radiation therapy. Again, this is just all generalized information. We'll get into specifics with each cancer diagnosis, but radiation therapy in general, we're using some type of high dose radiation to a specific site to cause cell destruction, cell death. It's not a systemic approach, so that's going to be, we're going to talk about in a minute with chemotherapy. We can really direct this to a specific area and hopefully kill just the cell growth and cancer growth within that area. But it's also going to affect that surrounding tissue as well. And a couple keywords. So the exposure is just really how much radiation we are delivering to that patient itself. But then we also have the radiation dose, which is how much they're actually going to absorb. So just because we have a specific dose that we're going to expose them to does not mean that the patient will absorb all that radiation. So there's two different words there. We have a couple different options for radiation therapy. We have external beam radiation. So the radiation is going to occur from some outside source. So we'll have this big old machine and we can directly aim it at a site. And I'll have a picture in a second to show you. And that's how we're going to deliver that radiation therapy. We also have the IMRT as well, intensity modulated radiation therapy. Instead of one big beam, I can have several thousand beams. So I can really shape that where that beam is going to directly specifically hit the exact site that I want it to. And we have, it's called internal therapy. You also see it as brachytherapy, where we can actually implant a radiation device within a certain part of the body. We actually leave it there for a while, and it gives low dose radiation therapy for an extended period of time. So it's just a slow, continuous round of radiation therapy. Internal therapy is going to be big for like your prostate cancers, your cervical cancers. That's typically where we see it at. This slide is going to pertain to our safety, but also the patient's safety. How do we protect ourselves from radiation therapy? If we don't have cancer, we don't need that radiation therapy because then it could cause cancer itself. Three big keywords are going to be time, distance, and shielding. When you think about radiation safety, think time, distance, and shielding. Time. How long am I exposed to that radiation therapy when I'm delivering that radiation? So you want it at least 30 minutes or less. Less time, the better. We're also going to try to coordinate that care. We're not going to go in the bath and then 5 minutes later bring their meds in. Oh, I got to start an IV a couple minutes later. Oh, I got to do trach care a couple minutes later. We're going to try to get all that done in one little go at it. So we can try to stay out of that room as long as possible and not be exposed to so much radiation. Nurses and techs and physicians that are working closely with this radiation therapy, they can wear a little dosimeter as well, and it actually will show how much radiation they're exposed to. So they know if they need to stay, if they can stay in there longer, if they need to try to limit themselves from that. Distancing. Definitely want to distance ourselves as far away from the source of radiation as possible. So if we're taking care of them at least 6 feet away, we're definitely going to tell the family members as well, and you probably need to stay about 6 feet away. Does that mean at the foot of the bed? No, that's probably not 6 feet away. You need a little bit further than that. And then shielding. So definitely wear some type of lead apron. We're also going to encourage no pregnancy with this as well. So if you're dealing with radiation therapy, just be aware of that. No family members that are pregnant as well. And no one under the age of 18. It's also going to be big.
Why does it matter if they're under the age of 18?
They can make their own decisions at that point. So we're just trying to protect the kids. Kids can absorb a lot more radiation. I hate to say more radiation. Less radiation can cause greater side effects in kids because they're not able to handle it as well either. So,
Do you make exceptions if it's their child? Like say if it's the mom or dad that has it, is there exceptions if it's their children?
I would strongly encourage them not to, but it's ultimately their decision. We can give them the facts, but we strongly, highly encourage them not to. So like even in ICU, we're not allowing kids under 12 just for their protection. we strongly advise against it, but they bring them in anyway. So it's ultimately your decision on that end. I would definitely know how to protect yourself from this. Just throwing that out there, and your patients as well. Meredith, what you got?
Oh, I was just curious, why does the lead apron not need to cover the head? Like, is the brain important?
Brain's kind of important.
I mean, you
yes.
know what I'm saying? Like, why doesn't it even at least cover the back of the head?
So this one's just a sample of a lead apron. So it even goes up and protects the thyroid as well. I've never seen a lead vest for the head. That's kind of a great question. Have you ever seen a lead vest for the head? Because he's X-ray, so he wears them all the time. They're very heavy as well. You don't ever want to do CPR in them because it's awful. You will die quickly yourself. So anyway, they're very heavy, and make sure you have the right size, the right fitting. That's the other problem I run into. So I have to help out in cath lab a lot sometimes. And I'm a big guy, and they don't have a lead apron big enough. But anyway, different story. All right, so this is some different techniques on how we're going to deliver that radiation therapy. So you see your patient here. He's got this little, it's almost like chainmail. It's kind of like a mask that's going to protect him from specific radiation to specific areas. And if we want to deliver that high dose of radiation to a specific spot, he can wear this mask, and we can actually deliver it to a certain area around him. Plus, if we have this mask, he can wear it every single time, and I can actually deliver that dose to the same area every single time he comes in for that radiation therapy. You'll also see, like in other parts as well, where they have what we call radiation markers as well. So it really looks like just a big Sharpie. It's almost kind of like arrows, set lines that the people delivering the radiation can line up these lines with the markers on their chest, for instance, and we can actually deliver that radiation to that specific area as well. Definitely don't want to wash those off. So if you see that on your patient, don't try to wash it off. It's got there for a purpose. And you'll see it, and they'll tell you too that they have radiation markers as well. Main thing is we're trying to replicate the procedure every single time they come in. Because even if we're like a centimeter or two off, we're not delivering that radiation to that exact area that we need to. But kind of hard to see. It's a little bit smaller. I got a bigger picture later. But this what's that internal therapy or that brachial therapy. So on the far right, this is how they actually do the therapy. This is for prostate cancer. But they have that probe, they insert it so they can actually visualize the prostate itself. And they'll go in with these pretty decent sized needles and they'll actually implant the little seeds around the prostate so it delivers that continuous slow dose of radiation. That looks pretty painful to me. But anyway.
What was that called?
That's your internal therapy or your brachytherapy. The very bottom right there in the red, that's what on that picture, the brachytherapy. So when I'm delivering radiation therapy, I am definitely going to have some side effects. The big side effects are going to be on box 18.4, page 388 of your textbook. And it's really going to be specific on where we're delivering this radiation. So am I delivering the radiation near the scalp area? Definitely going to have some type of alopecia, some type of dermatitis around that area. Maybe they have testicular cancer and I'm delivering radiation therapy there. That's going to cause some sexual dysfunction, cause some infertility issues. Same as cervical cancer. I highlighted skin reactions in red. The skin reactions is your big side effects that you're going to note or see. So we're going to have to educate our patients on proper skincare. So can y'all give me some examples of proper skincare, some sensitive skincare, how we would be sensitive to their skin? What are some things we could do? What do you think? Skin moist. Encourage hydration.
Silver, whatever that silver cream is.
Silver cream. All right, so we've got to have specific powders, creams. That's good. Hydration, I like that.
Magic mouthwash.
Magic mouthwash, we could do that. What about when we're bathing them? Do we need really harsh soaps? No. We don't need those really fragrant type soaps that smell real good, but they're probably a little bit more harsh to the skin. So we need some type of neutral type soap. We're going to rub their skin raw with these old, terrible washcloths in the hospital because they're not soft at all, right? All right. Are we going to rub it all?
I would say no.
No, probably not. We're probably going to pat it dry as best we can. Avoid that friction. If we have to rub a little bit, rub as gentle as you can. Use a real soft washcloth. Those types of things. So some type of mild soap. Only approved powders is what we're going to use. No type of heat exposure. So if they are having to go out in the sun, let's educate them on clothing options that they can use. So long sleeves, maybe some of those fishing shirts that are real soft that can protect them from the sun. And again, specific washcloths, able to pad dry. We're not going to rub the area real raw. We try to get it as clean as we can. those types of things. So skin reaction is very important for radiation therapy. Some of the later signs, you have pericarditis, so just inflammation around the sac of the heart, which can cause some perfusion type issues if we don't get that treated sooner. Coronary artery disease, some type of intestinal injuries, lots of different things. They're really specific depending on where the radiation therapy is going to be delivered. Okay. Nurse is caring for a patient undergoing internal radiation therapy or brachytherapy. Which of the following actions demonstrates appropriate radiation safety precautions? Heard C. Everybody like C?
Yeah.
All right. Nurse organizes care to limit time in the room, wears a lead apron during patient interactions. Good. I like that. Nurse remains in the room for the entire 30 minutes of the assessment period. That's just too long. We're trying to limit exposure as best we can. Standing at the foot of the bed, that's not enough length. So 6 feet or longer. Frequent visits. Stay as long as possible to provide emotional support. Yes, we do want to provide emotional support, but we kind of have to limit it at times while they're getting their radiation therapy. Okay. Is this the same one? This is not the same one. All right. Patient receiving internal radiation therapy for cervical cancer. Which instruction should the nurse give to the patient's family to ensure radiation safety? D. I like it. Maintain 6 feet of distance from the patient and limit visit time for 30 minutes per day. So no pregnancy. Definitely need to have 6 feet or more. And then 30 minutes or less. Okay. Is radiation safety important? Yes. Okay. We'll switch over to chemotherapy. So chemotherapy is going to have that systemic approach to it, something that we can give IV. We're really trying to interrupt, again, that process of cell regulation to prevent that overgrowth, to cause that cell death to occur, to hopefully kill off most of those tumor cells. Really specific on what type, where it's located, the health of the patient overall. Are they able to tolerate chemotherapy? Chemotherapy is pretty aggressive treatment. So it's really going to be dependent on the overall health of the patient. Chemo is not specific, though, so it's going to cause death to regular cells. It's going to cause death to the tumor cells as well. So the big one here is pancytopenia. What's that word mean?
Pancytopenia?
Yep.
Probably change shape.
Change shape. Not quite. So pan means all around, right?
Yeah.
Cyto is cell, and pena is lack of. So all around, we don't have any cells, basically. So that means white blood cells, red blood cells, platelets, all the above. You name a cell, we don't have enough of it. So anemia is going to be a big issue with these patients. We have a couple of different categories that we're going to talk about. Antimetabolites, it's a couple slides down, so you have to write it down. Anti-tumors and alkylating agents. Who can administer chemotherapy? RNs only, right? So no LPNs. Right? When we start chemotherapy, are we just going to walk away?
No.
Okay. How long should we stay in the room?
30 minutes.
So about 15, 20 minutes or so. We're going to frequently monitor them, monitor their vital signs, monitor their mental status, respiratory status, things like that. We're going to assess their IV site. So every time I'll push medicine, what do I always ask?
Is it painful?
Is it painful? What else?
Look at it, see if it's red, infiltrated.
Infiltrated, all right. So here's the IV infiltrated. We're going to talk about extravasation as well in just a second. All right, so only specialized RNs is going to be even further specific. You starting out, just, what's up?
I'm sorry, but I had to say what I saw in clinical because it was, you just said about needles. So I had to go draw blood, and I got the first patient. The second one, I didn't get her. So I was going to cap the needle because I didn't already stuff in the patient, but I didn't give you flashbacks. So you know what they told me?
What's that?
To just put it back in.
Yeah, no.
I just thought that was kind of just, you said something about IV, so I was like,
Stick is one and done. If you don't get it, you don't get flash. Just engage the safety and chunk it away.
I feel sorry for the patients now.
But especially trained RN is going to be the one that has to give chemotherapy. So you can actually get chemo certified. So when y'all first graduate, you won't be able to give chemotherapy agents. And it used to be 6'4", may not be anymore. But they're most all of them are chemo certified because they give a lot of chemo drugs on that floor. So it's just another little certificate, but you got to be specially trained for it. I'm not trained for it because I never had to give it. So you got to wear special gowns, got a double glove, any type of Waste, so any type of urine or stool, definitely got a double flush. Got a double bag. They gotta have special clothes.
Special bins to get.
Special bins to get rid of it. There's lots of things. So I would definitely know about. I would know about administration of chemotherapy. Okay. First class we're going to talk about is the anti-metabolites. We're not going to get very specific on these chemo drugs. Once you get actually trained on the floor and you start giving these chemo drugs, you're going to get some on-the-job training and you'll get more specifics. This is just generalized information for these types of things. Okay. So your anti-metabolites, our goal again is to break up that cellular regulation process to prevent them from replicating. With a lot of these, they're going to be nephrotoxic, so they're going to be really damaging to the kidneys. Definitely going to have some type of dermatitis, some type of skin reactions if we have infiltration that occurs. So we're definitely going to encourage hydration as best we can. We're trying to flush out those kidneys as much as we can, but as the patient tolerates it. So if they have CHF as well, or they have fluid overload, and you can hear it down in their lungs, maybe not as aggressive with our hydration. This is one that you're going to see a lot if you do give chemo-type agents. Doxorubicin. It's also called the red devil. Is that the term for it? When you give this, it turns all of their fluids red. So if they cry, it's going to be in red. If they urinate, it's going to be a red tint to it. Sweating, they're going to have a red tint to it. That's all the bodily fluids. They're going to have this red to it. This is a pretty intense, harsh type of chemotherapy drug. So doxorubicin is going to be one that you're going to know. So you got to pay special close attention when you're giving this drug. A big one is going to be that severe tissue damage with extravasation. So it's going to be toxic throughout the cells, but it's also going to be toxic throughout the veins that we give it to. Definitely going to have more than probably just a regular old peripheral IV that y'all see at clinical most of the time. A lot of times they're going to have some type of port, some type of big central line, and that's what we're going to give these drugs through. Something a little more stable type access. But just because we have stable access doesn't mean that the veins further down are going to be able to tolerate it well. And so when we have extravasation, it's when the fluid kind of leaks out of those vessels because they're damaged or have a little bit of a tear or a little bit of rip in it because of such of these harsh drugs. It causes the drugs and other fluid to kind of leak out in the surrounding tissues, that's surrounding space right there. And then we can have what this is.
And it all occurs out.
Yep.
How would you treat that?
It sloughs out and you have to do wound management.
So really just wound management, wound care. If it's going to swell even further, they can do what's called a fasciotomy as well to relieve the swelling and the pressure around the surrounding tissues. So they'll basically fillet open the arm, allow for that swelling to occur. Eventually the swelling will go down, and then they can close it back up as well. We can do skin grafts as well. If it's extensive enough, we can do that. But it can get so bad, so necrotic, where they might even lose that limb. So definitely want to be real careful.
And you said that's from the red devil.
The red devil. Yep.
So is this the last line of medication?
It's an intense medication. We'll say that. A lot of these are going to be the combination therapy. So they'll get radiation and chemotherapy, or surgical intervention plus radiation or chemo. Okay. Alkylating agents. We're preventing that DNA to RNA synthesis. So again, that's going to cause a breakup in that cell division process to occur and cause cellular death, cell destruction. We're going to continue to aggressively hydrate them as best we can because this can be nephrotoxic. With your alkylating agents as well, we're going to do a really great neuro exam because it can cause seizures as well. So what's a great neuro exam consist of? Natalie, what you got?
Well, you can pinch on, like, you can do a sternal rub.
Sternal rub, okay, for assess for what? Pain?
To see if they're able to react to stimulus.
Okay, what else?
You can do perla.
Perla, okay. So pupils are equally around and reactive to light. The
You
A is
can do
accommodation as well, so if they're able to follow your pen as well. You'll always say perla, but I know you'll never do the accommodation part of it. So, okay, what else?
Oh, what else? You can do different reflexes and see if they'll grab.
Yep, so if they can able to grasp your hand properly, are they able to follow commands? Some of those are real subtle reflexes or just basic instinct reflexes. So even if there's some type of neuro damage and you still put your finger in their hand, it's going back to that basic pincer grasp, the pincer grasp. and so they may still squeeze anyway. You can have what's called a corneal reflex as well. So if they're able to blink or not. It's natural for you to blink when something comes at your face. You have that kind of startled response. You're supposed to blink, but you can also get like a little sodium chloride flush, and you can actually just drop a little bit of the flush into their eye. It's just like contact solution, so it's not really harmful. They're supposed to blink. And you'll even see some of the neurosurgeons and the neuro guys take like a little bit of a gauze and actually touch the eyeball with a gauze. I don't like that method as much. It seems painful to me, and a lot of times they won't blink. So a really good neuro exam is what we're going for. With all those chemo drugs, we're also going to have severe nausea and vomiting. So we probably want to get some antiemetics on board as well. So what's a good antiemetic? Zofran. What else? Phenergan. I like Phenergan. Ativan's always a good last resort as well. Reglan. I like Reglan. I like Ativan because it has a dual purpose, but that's a last ditch effort. You're not going to get a whole lot of physicians ordering Ativan for it.
Can we use like scopolamine for patients?
You could. Yeah. That's good. So that's done with our chemo agents right there. Now we're going to move on to generalized cancer type emergencies, whether it be from treatment or just in general from the tumor being in a specific spot or area. Some common emergencies that we might see. So did y'all talk about SIADH last semester with Dr. Fuller? Okay, fair enough. So syndrome of inappropriate antidiuretic hormone, SIADH. All right. So your antidiuretic hormone is going to be this hormone that is produced by the posterior pituitary gland, and it really helps the kidneys regulate how much water is in circulation. How much fluid do we have on board? Do I need to hold on to that water because my volume status is a little bit low, so I need to bump up my fluid status? Or I have too much fluid and I don't need to secrete as much to allow me to excrete that water off. So with syndrome of inappropriate antidiuretic hormone, I am actually producing too much of the antidiuretic hormone. So that is making me hold on to as much water as possible. So I have really increased amount of fluid within my circulatory system, which is going to cause some hyponatremia as well, which is low sodium. So sodium way lower than 135. So it's going to cause some serious confusion, some disorientation. These patients really act, they are just really out of it. And once you fix their sodium levels, they'll get back to their old normal self. The sodium can play a big role in that. Seizures, if you get down low enough, weakness, even death. All right. So how are we going to fix your SIADH? Main thing is we've got to fix the issue in the first place. So is there a tumor within the posterior pituitary gland that's allowing too much excretion of the antidiuretic hormone? So maybe we need to remove that tumor or add radiation therapy, something like that. We're going to monitor their fluid levels. So if they have too much volume, do I need to let them just drink gallons and gallons of water? No. Okay. They're probably going to be mad at you because they're always going to be thirsty. They're always going to want something to drink regardless of what they are. And so they're going to want some type of fluid intake. But we've got to monitor that real closely. And for once, we're actually going to tell them to actually take some salt in. We're always telling our patients never to have salt. But we got to correct that sodium imbalance. We got to get it back to that 135 to 145 range. We don't want to do that too fast or too aggressive because it's going to actually cause increased pressure within the brain. So we'll have increased cranial pressure if we elevate that sodium level too fast. So there's specific protocol per facility and per physician. You're only going to see like 2 to 3, maybe even less points on your sodium level within like a 24-hour period. So it's a real slow process over a couple of days. Usually, if they're really confused or out of it and they're not able to have PO intake, we're going to give it through their IV. So we can get something like 3% saline. So it's super salty compared to just the regular old normal saline. And that's how we're going to monitor those levels real closely.
This only happens for a tumor on the pituitary gland?
It can happen other ways too, if it metastasized or something. Something's wrong with that posterior pituitary.
Are they going to give them diuretics?
We can give diuretics.
Are you going to see like JVD or whatever blood symptoms?
We can. So that's a good example. JVD, big one. You're going to hear those crackles within your chest, within your lungs, some of those fluid overload. Maybe you have some swelling and edema in our lower extremities, some of that pitting edema. This is another one, tumor lysis syndrome. I like this slide a lot too. It's pretty cool.
You like that last slide a lot?
I did not. Tumor lysis syndrome. So if we're treating these cancer patients, our end goal is for that tumor to decrease or disperse. We're trying to kill off those cells as much as possible. But we got to think about the aftermath of killing off these cells. So when we break down these cells or kill off these cells, they are going to excrete cellular type content or byproducts within our circulatory system. And that's how we develop this tumor lysis syndrome. So we're going to have really elevated potassium levels or hyperkalemia. Uric acid levels are going to be pretty high. We're going to have something called rhabdomyolysis. So everybody should know what rhabdomyolysis is at this point. Bella, what's rhabdo?
Muscle breakdown. Damage.
Muscle breakdown damage. It's very similar. Okay, good. What's it going to do?
Is your CPK high?
Your myoglobin is going to be clogging up your kidneys, right? Okay. So it's going to be very similar. It's any type of cell breakdown, any type of muscle breakdown. That's how we normally see it. It's going to have a very similar presentation. We're going to have some big time electrolyte imbalances. That's going to be one of our number one signs and symptoms. So we're going to have some elevated hyperkalemia, hyperphosphatemia as well, have hypercalcemia, a lot of these electrolyte imbalances, cramps, nausea, vomiting. If we have that hyperkalemia, we're going to have some cardiac changes, right? Yes, going to have some big EKG changes, which could result in death.
Is it similar to like if they had severe burn or something like that too, where you get this big dump of cellular contents?
Good, very similar. So it could be something like you said, a burn. The burn is going to cause all that cell destruction, all that cell byproduct is going to be within the circulatory system. Trauma could be a big one too. So sometimes you'll see these like really healthy boxers come in and like rhabdo or something similar to this because they got repeatedly hit within the kidneys or in some type of musculature. So it's breaking down those cells, causing that byproduct to get into the circulatory system. So good. Our goal with treatment is going to be to correct those electrolyte imbalances. First and foremost, we're going to aggressively hydrate them again. We're trying to flush those kidneys out as much as possible. We can use some loop diuretics as well. What's a loop diuretic? Good example.
Furosemide.
Furosemide, good. Or Lasix, because that's actually going to decrease my potassium levels, right? Good. It's not potassium sparing like spironolactone is. Furosemide's a good one. How else can I treat hyperkalemia? Lactulose, close. What's the other one?
No, it's
Oh, insulin and black calcium. No, look at
Insulin and D50. Okay, so that's one. The lactulose is for ammonia levels. There's another one that makes you poop.
the Three Musketeers.
Is the KX?
KX-lite, good. All right, so KX-lite is going to be another big one. It's going to withdraw all that potassium within that circulatory system and basically poop it out. You always give it right before you go off shift. That's a big one. What's the other name for KX-lite?
Oh, I do know it. I just can't think.
excellent.
No, not quite. Polycistrine sulfate.
Yeah.
Okay. You're probably going to see that versus the KX-lite.
Why is there another name?
You're going to have the difficult names on there. I'm sorry. Just what it's going to be. So Natalie mentioned insulin D50. That's going to be a short, quick fix. All right. So insulin pulls potassium back into the cells. But since we're giving insulin, we're going to drop our sugar. So we give that D50 to help out. But that's really just a Band-Aid. Eventually, over time, it's definitely going to increase back up. You can also do dialysis as well to filter out that potassium. Again, that KX-late or the polystyrene sulfate. We can get diuretics. We can also get fluids. All right. Please make sure you know how to treat hyperkalemia. Right. Superior vena cava syndrome. You think about that. Where is the superior vena cava?
That's the top of the one.
Top of the heart. It also says it on the slide too, so if you don't know. Top of the heart. It's the big vein, a big vessel that's allowing for that blood return from the head, from the chest, from your upper extremities, and dumping it back into that right atrium. With superior vena cava syndrome, we have some type of tumor or some type of obstruction around that area that's causing compression on that superior vena cava. With that compression, it's basically going to clog up our system or back up our system. And so we're going to see edema or excess amount of fluid anywhere back from the superior vena cava. So the first place you're going to see it is in the vasculature around the upper chest. You're going to see some facial edema as well. It can eventually get worse enough where it's actually going to cause some buildup in the lungs. About the only way we can cure that is to remove that cause. So whatever tumor or obstruction is causing that clamping down on that superior vena cava, remove that, we can fix that issue.
Isn't this the reason why pregnant women can't have back?
Partially, but that's more for
Kind of
down the
pressure.
lower the iliac veins right there. That can cause poor perfusion to the kidneys. As far as I'm told, I don't know a lot about pregnant people. So anyway, good picture. This is also in your textbook as well. What we can see here, some of the vessels starting to pop up. We're starting to see some edema up here, facial edema up top as well. It's really that backflow of that excess fluid because we're not allowing it to dump back into the heart to recirculate. Questions about superior vena cava syndrome? Nope. Okay. Spinal cord compression. It's going to be our second to last. I was about to say last emergency. No, we're not talking about, but second to last. So this can happen in two different options. So we have a tumor directly pressing against the spinal cord causing issues, or we had some type of bone metastasis or some type of bone cancer as well that's causing that bone to break down, to deteriorate. And over time, that pressure and the way that the bone deteriorates is causing pressure on that spinal column or on that spinal cord. Your symptoms are going to be real specific to where along the spinal column that it occurs. Right? So you got to remember there's nerve endings all along that spinal column. And depending where it is, what function that it's going to affect. Usually it's going to be within that thoracic cavity area. So the 12 vertebrae right there. Big symptoms are going to be the back pain, your muscle weakness. You're going to start to have some neurodeficits as well. So numbness and tingling in your hands and feet. You might start to lose some of those deep tendon reflexes. Maybe troubles urinating. Maybe troubles with incontinence, depending on where it is along the spinal cord. So we got to remove that cause, if at all possible. Try to get as much of that tumor away as possible. And a lot of times we're going to try to decrease that swelling through steroids, but we're also going to have radiation therapy as well to kill off as much of that tumor as possible to cause it to shrink and relieve some of that pressure along that spinal cord. We can have some back braces as well, especially fitted to our patients to have a little bit more stable of a spinal column as well that doesn't cause as much pressure on that spinal column. It's kind of like a compression sock. It kind of squeezes everything together to hopefully reduce some of that pressure along that spinal cord. All right. So X-ray here, and then we have a tumor that's causing a little bit of compression along this spinal cord. You can kind of see it bulging out right here. It's causing compression along the spinal cord. We have a second one as well. This one is from a fracture. So we had some bone deterioration over time, causing a fracture and pushing along that spinal column as well. You're not going to have to interpret X-rays, but I just want you to get a visual of what I'm talking about. All right, last one of our emergencies. Hypercalcemia. This is going to be more specific for your myelomas, any type of metastasis disease of some sort. So cervical cancer migrated toward the bone, and we start to have that bone deterioration or that bone breakdown. That's when we're going to have this occur. You got to remember there's a lot of calcium circulating within the bone. So when we have that repeated bone breakdown, we're going to have a lot of release of calcium itself. So that's how we're going to have that hypercalcemia. Big ones here is going to be your EKG changes. So we're going to have that shortened QT interval. So your P wave is what your atrium is beating, right? QRS is when the ventricle is beating. T wave is when the ventricle is relaxed. So between the period of the ventricle beating and relaxing, that's what's going to be shortened, that QT interval. We're going to have some neuro changes as well. Calcium plays a big role in muscle contraction. So they have a loss of those deep tendon reflexes as well. You might have the Chbosky sign or the Trousseau sign. You know what those are? You remember Alan?
No.
Okay. So Trousseau sign is where you put the blood pressure cuff on it and your hand kind of clenches up. The way I remember that sounds Italian to me. And so I think Trousseau's. Okay. May not be the best way to remember it, but that's how I remember it. Okay. And Chbosky sounds like cheek to me. And so that's when you tap on the cheek and you have a little bit of a twitch within the cheek. Okay. Paralytic ileus. basically your intestines, your colon has basically stopped, and now we have an obstruction occurring. How are we going to treat this? So again, those loop diuretics, we named Lasix, furosemide. We're going to do aggressive IV hydration again. We can potentially do dialysis where we filter off some of that calcium. So with most of these, aggressive hydration is going to be key. Questions about hypercalcemia? A few questions and we'll take a break.
I'm sorry, when you say aggressive hydration, how fast?
I mean, we're not going to, we can bolus them if they're really acute and symptomatic, but we're going to give them an excess amount of fluids up to like 3,000 mLs or more of fluid to really flush out their system. And also going to depend on their kidney function as well. Are they able to tolerate those fluids? They're also their cardiac function. Are they able to circulate like they're supposed to? There's going to be a lot of factors included. Nurse is monitoring a patient receiving chemotherapy. Which finding is most indicative of tumor lysis syndrome? Or B. Who likes B? No one likes B, but clearly. Oh,
Okay,
okay. Never mind. I'm sorry. Yeah, B. I like B. Muscle weakness, nausea, and hyperkalemia. Remember that tumor is breaking down. We're having that cell destruction to occur. So it's releasing all of that byproduct, that cellular contents, back into the circulatory system. So that's where we're going to get those EKG changes. We're going to have some of that hyperkalemia and muscle weakness. We all know how to treat hyperkalemia, right? Yes. Good. Nurse is assessing a cancer patient with suspected SIADH. Which clinical finding supports this diagnosis? So syndrome of inappropriate antidiuretic hormone. Oh, too far.
B.
B. Maybe.
Wait,
C.
C. Hyponatremia with confusion and seizures. I kind of like B as well, but I like C more.
The fluid
Yes,
overload.
we do have fluid overload, but we're going to have some hyponatremia in there as well. We may or may not have hypertension based off the fluid overload, but we're definitely going to have low sodium levels with some confusion with potential for seizures. Patient with multiple myeloma develops confusion and nausea. Which laboratory result would the nurse expect?
C.
Heard A and I heard C. So multiple myeloma, that's within the bone.
Should make the calcium high.
Should make the calcium high. What's the normal calcium level?
9 to 11.
9 to 11. Okay. Is that what it says on the freedom?
I remember calling 911.
No, I thought the two.
I thought it was like 9 to 10.5.
I know 8.6 to 10.2. But roughly that. All right. So 12.5 is elevated for all of our values, right? Okay. So C, 12.5.
Heard it. Yeah, it was 9
Is there
to
a lab value you just
911 for
remember?
hypercalcemia.
8.6 to 10.2?
Whatever it says on that sheet. There's a
The-
clinical, on the clinical spot words, whatever it says, a set of lab values that I need to know. Those are the lab values we need to know.
It's not, somebody just say good like myself.
All right. Let's get started. Now that we've talked about cancer basics, generalized cancer treatments, how we grade, how we stage, let's get into more specifics. So don't forget about the first half of the lecture. That stuff's going to apply to this section as well, but we're going to get into the specifics of each type. 8 different types here. We're going to start off with testicular cancer and work our way down. With testicular cancer, we are going to classify it into two main primary groups. We have the germ cell tumors, and then we have the non-germ cell tumors. Germ cells are what produces the sperm. Then we can further break it down into seminomas and the non-seminomas. Your seminomas are going to be your most common type of germ cell testicular cancer. The non-seminomas are pretty rare. We also have the non-germ cell type. And these are going to be the cells that produce other stuff like your testosterone. So they don't produce your sperm. Typically, this is going to occur with patients 15 to 45 age. It's pretty common to see in really young adolescents, which can be hard to treat because they're not going to get help a lot of the time. Typically, testicular cancer is going to be real localized. It's going to be a slow-growing type of cancer. If we catch it early enough, it's really easily treatable. And it usually is not going to metastasize further out until you get to real late stages of testicular cancer. Got some of the risk factors down at the bottom. So you got your cryptokidism. Anybody know what that is? It will not drop. The testicles will not drop. It has not descended down. So it's still kind of, lack of a better word, tucked up under there as well. Infertility issues, HIV, marijuana use, a lot of dietary fats, potential risk, and hypospadia as well. What's hypospadia?
Where you're feeling hot.
So your urethra is on the other underside of the meatus, right? So when we're getting at signs and symptoms, we're definitely going to get a good, adequate patient history when we do this. So did they have any of those types of risk factors? Are they having infertility issues? Do they have cryptokidism, hypospadia? Do they have a previous history of testicular cancer? Or do they have some kind of genetic history of cancer within their family? Patients are going to report just a painless lump or swelling along one of the testicles. It's not going to be mobile. It's going to just be a firm, hard mass. It's going to be painless. And then eventually, as the cancer progresses, it's going to progress within those lymph nodes, those inguinal nodes along right down the abdominal area. So that's why it's going to be critical to assess their mental status, their psychosocial status. If you tell a 16-year-old kid that he has testicular cancer, they're all awkward at that age anyway. Hormones are raging. They do not want to talk to their parents or their healthcare provider about testicular cancer. So it's going to be a big mental health issue. Even further, if you have someone that's older, one of the treatments for testicular cancer is just going to be to remove the testes. All right. So that's going to be a big mental image for them. They're going to be that body dysphoria. They don't have a testicle, and so they're going to be ashamed of that. Lack of a better way, men, that's one of the things they care about, So it's going to be a big mental issue for them. Diagnostic-wise, your two big ones are going to be your beta-HCG and your alpha fetoprotein as well, and which is a pregnancy test. Okay, very weird, I know. Early on in my career, I had a physician order a pregnancy test on a guy, and I went up to her. I was like, I think you ordered the wrong test. And then she gave me like an hour lecture on how this is appropriate for specific prostate cancers and testicular cancers. So there you go. So the beta-HCG, it's a pregnancy test. You're going to have high levels of that beta-HCG, and you're also going to have high levels of that alpha fetoprotein. Right? In fetal development, if you have high levels of alpha fetoprotein, you're going to have some type of fetal distress, and that's why they're going to have higher levels of that occurring. Usually in adults, you're not going to really have much level of that alpha fetoprotein until some type of cancer develops.
So should guys just take a pregnancy test every so often to see if it's possible?
I guess you could. You could have some
that
false.
would be a diagnostic.
You could have some false positives, but yeah, it's very weird. It really shocked me when she ordered that test, and then I felt really dumb because she humbled me. But anyway, so you learned something new every day. This is a very painful looking picture. But my Google search history is very off on this one. Anyway, so a couple options for treatment-wise. The non-surgical route. We can administer chemotherapy and radiation therapy to the affected testis. So remember back to our chemotherapy and radiation type of stuff. Your sperm banking is going to be very important for this. We're giving high-dose radiation and high-dose chemo to treat this testicular cancer. It's going to cause some infertility issues. So we need to discuss with our patients about sperm banking or sperm preservation, something along those lines. So they'll go to the bank, have it stored. They can have it basically frozen for however long they want it to. And it's really almost just as effective as the old-fashioned technique. Okay. So surgical options. We have what's called an orchiotomy. So that is the removal of the testicle. So they'll make that small incision right there within the groin. They'll actually just kind of pop it out of the sac and then cut away that disease testing. They do have options for implants. And so you can actually get like a little silicone prosthesis. Yes.
I used to work for plastic surgery and I've seen this.
Okay.
It's very odd.
Yeah, I would imagine. I've never seen this in person.
It looks
uh,
like basically a mini a boob job, basically like they're little mini breast implants.
Right, exactly, and that's what I was
Yeah.
gonna say is it's just a little silicone implant, very similar to when they have breast implants, but they can actually put it in the testy, and so then it looks like you have both testes again, and that's really good for their mental health. So that's definitely an option we can suggest to our patients. Then we have what's called the laparoscopic retroperitoneal lymph node dissection. So this is gonna, I know that's a big mother word, RPLND, but this one's a little more invasive. All right, so this is going to be for more of the bigger stages of testicular cancer when we start to have invasion of the lymph nodes in the surrounding area within the inguinal area, within that groin area. So we can actually take out the testes, and we can also remove the lymph nodes in that surrounding area. With this, though, we do have some complications. Of course, we have the infection risk, we have the bleeding risk as well, but there's a lot of nerve endings within this area. So we can have some sexual dysfunction with it as well. And then we can also have retrograde ejaculation as well. So instead of the sperm coming out the urethra, it'll backflow into the bladder and cause some infertility issues as well. So post-op wise, we're going to monitor for signs and symptoms of infection. So redness, any type of exudate, drainage, any type of fever, elevated white blood cell count. We're going to educate our patients on wound care. So they want to have a nice, dry, sterile gauze, something that they can place within that incision area. We don't want any kind of clothing to pull along those suture lines, to pull out some of the sutures and possibly open back up that incision. So we don't want a lot of friction or rubbing along that area. We can also suggest supportive underwear as well, or immediately after we can support the testes with some type of pillowcase to kind of elevate those up to help support it. That way it's not kind of hanging there, causing some pressure along that incision line, causing some unnecessary pain. I've heard too, like you have a jock strap as well that kind of keeps everything nice and compact in there as well. So we can offer up some of those suggestions. What do I need to educate my patient on as far as testicular cancer goes? We need to really educate them on what type of resources are out there. They have those support groups. They have social services that can get them the necessary resources that they need. So if they need some type of supportive dressing, they can get them that. Maybe they need some mental health support. We can refer them out, get them some help that they need. They have sexual coaches as well that can help if that's an issue. Again, a big one is that reproductive preservation. We are altering the ability to produce sperms, whether that be radiation or having one less testicle. So that's going to cause a decrease in sperm production as well. So we need to preserve sperm if they so choose. And then that big one at the very bottom, performance of monthly self-testicular exams before and after. So even before we have a testicular cancer diagnosis, we need to tell, especially the young males, adolescent males, the importance of the self-testicular exams. It's going to be an awkward conversation, a conversation they don't want to have, but it's a very important conversation we have. It's highly treatable, highly curable, so if we catch it early, they won't have any major complications or major issues. And just because we have cured it and treated it beforehand doesn't mean that it can come back with another testes, so we also need to include that for our patients after they have been treated for testicular cancer as well. So this is just a poster that we can show for your self-exams. Usually going to do it once a month in the shower. You're going to grab one testicle at a time. You're going to kind of roll around in your hands to find any painless bumps, swelling, anything that may be abnormal to them. And then you're going to do that on the other side as well. They definitely want to familiarize themselves with their anatomy. So every guy's anatomy is a little bit different. One might be a little bit bigger than the other. Things might be placed in a different way, so they need to know their anatomy. So each month they know if something has changed. Questions about testicular cancer? It's pretty straightforward. What is the big test for testicular cancer?
HCG.
ACG and AFP. Okay, good. All right, moving on. Skin cancer. So look at table 21. Looks like a 2. 21.12, page 484. And that gets into your skin cancers. Talks about your types. We have 3 big main ones that we're going to discuss: the squamous cell carcinoma, basal cell carcinoma, and melanoma. Your biggest risk factor for this is going to be overexposure to sunlight. So the constant sun tanning, sunbathing, whether that be outside with constant UV radiation or within a tanning bed. They don't also necessarily have to be tanning. So a lot of the older generation, they like to work in the garden. They like to plant flowers. Maybe you have a job outside where you have repeated exposure to the sun. Before we talk about skin cancer itself, we have to define a few terms. So figure 20.8, page 433, is this chart right here. So it's kind of hard to see on the slide itself. It might be easier on your computer if you can zoom in. But I would look at figure 20.8, page 433, and it'll give you these exact definitions. So let's talk about a couple of definitions. So does anybody remember what a macule is? Skin is not, so like a mole or a freckle is going to be your common example of that. It's going to be flat, less than 1 centimeter in diameter. So real small. Again, remember something like a freckle. What about a papule? What's a good example of that?
It's a colorless mole.
Wart. Good. So colorless, like a firm, elevated type lesion. So just a little, almost like a little bump. All right. Still going to be less than 1 centimeter. Nodules. These are going to be more marble-looking lines, elevated. They're going to be a little bit larger. Going to be deeper within the specific layers of the skin. So it's going to be a little bit further down, deeper than that skin layer. They're going to be greater than 1 centimeter. Example of this one is going to be something like a lipoma on the skin. And then we got what's called plaques. So anybody have seen plaque psoriasis? That's patchy, scaly type skin. That's going to be what plaques are. Going to have a little bit of elevation with those as well. Okay. So let's move on to squamous cell carcinoma. So we're going to have a firm nodular lesion. We're usually going to have a little bit of crusting within the area, maybe have some type of ulceration along the middle. The edges are going to be nice and firm, and then you're going to have more of a softer area within the center. So that's what that indurated margin is going to mean. Big time areas are going to be your head and neck. Sometimes you can get these along the legs as well. Any type of burns, we can also have these start to occur. These can also develop from the keratinosis type lesions, which are the non-cancerous type lesions, and they can develop into the squamous cell carcinoma. So let's look at a few examples. I would definitely take a look at these pictures and familiarize yourself with the different types of cancer as well. Okay. So this is a deep ulceration, really rounded. We have that crusted center right there. If we were to palpate it, it would be firm in nature. So this is what kind of tells us that it's a squamous cell carcinoma. Another example. Got these yellow borders, have crusting around the middle. We definitely have some firm or indurated margins around the outside as well. So those are 2 good examples of your squamous cell carcinoma. All right. Basal cell carcinoma, a little bit different. It's going to be layers of the epidermis, not quite as deep. But that's just very rare on this one. But it is one of the most common types of skin cancer. So it's going to be a pearly papule. What was papule again? Yeah, so firm, elevated type lesion, less than 1 centimeter. So it's going to be that firm, elevated look to it. It's going to have that pearly appearance with a little waxy border. When I flip to the next screen, you will see. It's going to have a, let me attempt this, telangiostenosis. Ooh, that's hard to say. basically it's going to have visible blood vessels in that area. Definitely going to have some changes of color within this as well. Let's look at it. All right, so on the left here, see how it has kind of that pearly, shiny, glistening type appearance around the outer edges. We can also note some of the blood vessels starting to appear on that. We can even see that it's raised in this picture as well. Same with the right side. It has kind of that waxy, pearly, glistening type border. It looks like it's kind of rolling, kind of have like a crusted edge, rolled edge as well. You can't see as many blood vessels in that, but they're still there. That's a good example of the pearly, glistening type, waxy looking borders, edges. And definitely have those blood vessels within it as well. So that's two good examples of your basal cell carcinoma. Right. Third one we're going to talk about is melanomas. This is within the pigmented areas of your skin cells. So definitely going to have a varying in appearance, varying in color. These are the ones that we kind of traditionally think about. So it's going to have these really irregular type borders, non-symmetric in nature, the varying colors. So we can have some browns to blues to purples, just very irregularly shaped, odd looking shape to it. It can definitely start out as like a mole or a birthmark in the early years, and then it can develop further into a melanoma later in life. Good example. So see how we have the varying skin colors? Some have some dark browns in here, some kind of intermediate brown, goes back to darker brown. Look at our borders, very irregular shaped. It looks like camouflage to me, but that's just what I think. Anyway, just has a very regular looking border to it, not symmetric in nature. Another good example. This one doesn't have as much varying color to it, but the borders are very irregular. It's not symmetrical in nature. So if I divided this in half, the top half and the bottom half definitely don't match. Question about appearances. Please know the appearances. In general, how are we going to treat skin cancer? A couple different options. The surgical route, and then we have the non-surgical route. Usually we're not going to do the non-surgical route. We're going to go more towards the surgical route. A couple options. We have cryosurgery. So typically we're going to have almost like a spray can of liquid nitrogen. And we're going to freeze that area as much as we can, spray that liquid nitrogen down on it, and hopefully cause that cell death to occur. Really, we're causing damage to that skin and to that surrounding area, almost causing a little wound or a little ulceration. It'll scab over and hopefully heal back in without any cancer cells. Now, the curvature and your electric dissection as well. It's going to be best to explain right here. So this is our little curette. It's got one little sharp edge. And so we're actually going to scrape the skin off within that area. And then we can also put a little bit of electrical current, not much, very small amount, to actually burn away some of that excess cancer cells. Excision, that's going to be where we're going to take our scalpel. We're just going to cut it out, plain and simple. And then we can have wide excision as well. So it's just a more extensive removal of that tumor. The Mohs surgery or Mohs surgery is going to be a fancier excision. So I'll go to the slide again. So with an excision, we're just cutting the tumor out, just one big hunk. With a Mohs approach, we're going to take it layer by layer and almost dissecting it and getting good, nice, clean margins. We can get really good biopsy off of this to send off to the lab. And it's a little bit better cosmetic-wise as well. Usually, we're able to get most, if not all, of the tumor with this approach because it's a slow, steady, constantly dissecting away little by little until we remove all that tumor. At top left, that's what I was talking about with cryosurgery. So it's that little liquid nitrogen gun. You point it directly at the site, spray it, and hopefully kill off that cell. Also use that a lot for wart removals as well. It's a pretty fun one. I like using that. I've done that a bunch. Here's an example of an excision. So we had a little bit of a carcinoma here. And then he had like a nice deep, long section there. And so we have a lot of those stitches right there, nice long incision to remove as much of that and get good, nice, clean margins or spaces or areas that are free of cancer. So that's what we're going to try to shoot for, clean margins. So the ABCDs of skin cancer. A, is it asymmetric? All right, so if I put a line through the middle of that mole or that suspected area, is the left side going to match with the right side? Is the top half going to match the bottom half? So is it symmetric or asymmetric? If it's asymmetric, potentially could be a skin cancer. So if we have a ding in any one of these, we definitely need to recommend to our patients, go to the dermatologist, get it checked out, and seek out treatment. B for border. So we really notified that or saw that within the melanomas. It's not a nice uniform round circle. It's kind of that patchy, wavy, irregular looking appearance. The color, does it change? So does it go from the purples to blues, the dark browns to the light browns? Diameter, is it growing? How big is that mole getting? Is it constantly changing? Has it stayed the same for years on end, but all of a sudden it's doubled in size? And then is it evolving? It's going to be our D. So are there new spots popping up? Or are any of the rest of these changing? Is it evolving in some form or fashion? Is it changing in some way? So that's your A, B, C, D, and E of skin cancer. All right, patient education is really going to be about protecting the skin. A lot of it's going to be based on exposure or sun exposure. How do we protect ourselves from that? A good box would be a box 21.18 on page 45. That's going to talk to you about all the education needs for skin patients. So, of course, we're not going to go out right at lunchtime to do our work. Maybe we need to do it first thing in the morning when the sun's not at the highest, not at the brightest, not at the hottest. Definitely avoid tanning beds. Use your sunscreen. Maybe wear appropriate clothing. Wear a hat. Wear the little scarves or buffs to protect your neck. Definitely look at your skin every so often. Stand in the mirror and just look at yourself. Is there any new moles that you haven't noticed before? Or the moles that you already have, are they getting bigger? I like the last bullet point. Take a picture of it if you're really worried about it. Okay. You can take a picture month to month. Keep a little journal entry of it, and it'll show you if it's evolving. And that's something you could take to the doctor, or you could show us as nurses and be like, yeah, there has been some type of change within that mold. Maybe we need to seek out some type of treatment. This is just another example of the ABCDEs of skin cancers. So is it a mole or is it a melanoma? I definitely won't read it to you again, but just some helpful side-by-side comparison of benign or non-cancerous cell versus non-cancerous cell. Which of the following is the most important teaching point to reduce the risk of developing skin cancer? Good. Avoid sun exposure during peak UV hours and wear protective clothing. I don't like A because it says only in there. Apply sunscreen only when you plan to swim or sunbathe. Definitely need to apply sunscreen more than that. Monthly skin not necessary unless you have a family history. Always check your skin regardless. Definitely don't want to use tanning beds. Okay. Answer C. Nurse is assessing a lesion that appears as a firm, crusted nodule with indurated margins on a patient's scalp. Which type of skin cancer is most likely?
C.
I really need to change up my answers. Everything is C. When in doubt, go C, right? So squamous cell carcinoma. What's our melanoma going to look like? Let's refresh.
Camouflage.
Camouflage, I like that. Irregular shape, irregular borders, varying skin colors, right? Squamous cell, we already said that. Basal cell carcinoma. Waxy, pearly appearance.
Most common.
It's going to have a telangiectasis, right? Or those little blood vessels.
And the last one. What's that?
Just little crusted lesions. It can turn into that squamous cell. Which of the following characteristics is most concerning for melanoma during a skin assessment? We just reviewed it, so it should be good. It's not C this time. So.
It's D.
It's D this time, yes. Dark papule with irregular borders and varying pigmentations. Good. Okay. Questions about skin cancer? All right, let's move on to colorectal. What I'm saying or talking about colorectal, I'm including the rectum and the colon, or the large intestine. I'm not talking about the small intestine itself, okay? And it can be anywhere along that tract of the colon and the rectum. So you have your transverse, your descending, your sigmoid colon. And how we classify it, or how we talk about it, is dependent upon the location within the large intestine, and then, of course, the staging and the grading of that tumor as well. You got to think, within that large intestine, there's a lot of blood vessels, a lot of lymph nodes within that area. So it's going to be very quick to metastasize. Those cancer cells get into the circulatory system, and who knows where they can go. Usually they're going to go to the surrounding organs first, but they can go just about anywhere. All right, so like I said, anywhere along the colon, and it's going to be dependent on where along that colon is going to be. So just a good example, we have ascending, transverse, and descending. Usually about half of the cases are going to be along that sigmoid and rectal area right in there. That's where you're usually going to find your cancers. Now, it can extend outside of the colon, so go up into the liver area. Some of the surrounding organs can be along the outside of the colon cells, any layer within the colon, and they can also be within the lumen of the colon, so basically on the inside, where the food and everything else is being digested. That pathway, it can grow along on the inside of that. These are going to be a lot of the symptoms that we talked about earlier with the caution symptoms, but some type of blood in the stool. They can't really pinpoint it, but some type of abdominal pain. It's really big. It comes and goes. It may not necessarily be sharp, bending over pain. It's just kind of there, kind of nagging type pain. Some type of fatigue related to anemia. So if they have a lot of blood loss within their stool, of course, their blood levels are going to be a lot lower. They can become hypovolemic even because they're losing so much blood. So we can have that high heart rate, low blood pressure, or perfusion issues. All right, so this is the colonoscopy images. You can see some tumors here along that colon. I thought this was a pretty cool picture. So, got some gas in there as well, some gas bubbles, some type of liquid, digestive enzymes. How do we diagnose colorectal cancer?
Biopsy.
What now?
Biopsy.
Biopsy, that's going to be a big one. Yes. What now? Cologuard. I know, I should put a picture of Cologuard on here. So your Cologuard, since we're mentioning it, is going to be your multi-targeted stool DNA testing. That's your Cologuard. We can also do the fecal occult blood test. That's not necessarily specific to colon cancer. That just is going to show that there's blood in the stool. And that's all it's going to tell us. So then we need to investigate a little bit further to see why we're having blood in our stools. So it could be a multitude of things, but that could be one of our first steps. Is anybody colorblind in here? No? Okay.
Not that I know of.
Not that you know of. Has anybody done one of these before?
In a different species.
A different species?
I've never done to me.
I'm sure it's roughly the same
But you
thing.
can test positive, you have a hemorrhoid too.
You could. So I mean, like I said, it's not specific to colorectal cancer. It's just showing the presence of blood. So that little wooden stick right there, you're going to get a stool sample from 2 different sources or sites. There's an A spot on the card and a B spot on the card. You're going to smear it on the A site. You're going to smear it on the B site from a different area within the stool. And then that little bottle on the right side is our control, or our little liquid. So we're going to do 2 drops in the middle. That's going to show our control. 2 drops on the A side, 2 drops on the B side. If it turns blue, then there's some type of blood within the stool. If you don't have any blue, then there's no blood. So that's why I was asking if people are colorblind. It's a harder time, of course, reading the results. The carcinoembryonic antigen as well is not specific to colorectal cancer. It's generalized to cancer, so it could be elevated. But our gold standard for colorectal cancer is going to be that colonoscopy. That's how we're going to get that best view and able to get a biopsy to treat or to test those cells for the presence of cancer type cells. And I think it's next slide. Yep. So we're going to be in the left lateral position. Definitely going to take a scope, and they can run the length of your large intestine to the other end. And you can notice if they have any diverticuli, they have any polyps, if they have any cell growth, potentially a tumor along the lumen there, they can actually take a biopsy of this so we can test it later, all with this camera. Of course, patient's going to be lightly sedated. We're not knocking them all the way out, but they're going to be sedated. The CT guided virtual colonoscopy is very similar. We're actually using a CT to go through each layer along the colon. And we can actually create a better picture sometimes than the colonoscopy. The only downside to this is going to be that we can't get a biopsy during this procedure. So that's why we usually go for the colonoscopy route. And then the sigmoidoscopy is really just going to go roughly to the rectum sigmoid area. It's not going the full length or traveling that whole colon. So usually we don't go for that one. We're going to go for the full colonoscopy. Of course, we can do a combination of therapies. We can do chemo and radiation therapy. We can also do surgical intervention combined with chemotherapy to really hit it from all angles. Big thing with surgical management is we're trying to remove as much of that tumor as possible. And so we're going to have to resect or take out part of their colon. So we can have what's called that partial colectomy or the total colectomy, one of the two. And then we're going to have a colostomy in its place. So our big points for patient education is going to be the colostomy education. How do we take care of our colostomy? So what are some good things about our colostomy? What are things on assessment, things I need to know or look for with my colostomy?
Skin irritation around the site.
Okay, skin irritation around the site, good. What else? Color of what?
Beefy
red.
The color of the stoma, good. So it's got to be beefy red. We don't want it black, right?
No, that's necrosing.
Okay, good. That's necrotic or necrosing. We want it moist a little bit. We don't want it dry. So that could be a bad sign of perfusion as well. And we need to have a ballpark measurement of how far it's sticking out of the site itself. The surgeon is going to note that, and he's going to come by and just see if it's protruding out further. And we have what's called a prolapse colostomy. Before we have a colostomy, we need to educate our patients. Low fats, low carbs, low fiber type foods. We need to bake or boil our food. Oh my goodness. Increased risk due to alcohol or sedentary lifestyle. Again, we have smoking as a risk. So those types of carcinogens. So that's what our colostomy stoma should look like. So we have that nice beefy red appearance. It's a little bit moist. There's no necrosis to it. It's not protruding through the insertion site or the incision site very much. Usually we're going to have about 1 to 2 inches. Compared to that one.
So I guess have to remove part of that.
So it's a little necrotic, right? It's dry. This one's definitely prolapsed. Okay. You will see some off-label treatments for prolapses where you put sugar around this site
To reduce it?
to reduce the prolapse and it'll actually go back in. That's not really a textbook thing, but you will see it in practice. So I've done it before. I don't think it helps a whole lot, but
So would you want necrotic tissue to go back in?
not with this one. If I noticed it prolapsing and I was able to catch it before it got necrotic, this seems like he was like in long-term care or at the house and didn't even have proper education and just didn't assess it as much, and it became necrotic from this. All right, so what's some at-home education that we can talk to our patients about? Anybody got any thoughts?
Cleaning.
Cleaning, okay, good. So clean around the site, pat it dry, keep it dry, not moist. That can cause some skin breakdown. How to apply the pouches, the bags. Those are always tough for a lot of patients to start with. Sizing, good. How do we size the stoma versus how big of a hole we need to cut within our bag to place it on our skin? We already mentioned before the condition of the stoma, so if it's necrotic or beefy red. So we probably could tell them if it stays red and moist looking, then that's okay. But if it starts to become black, starts to become a little dry, we probably need to let somebody know. Their intake and output. So they're getting adequate nutrition, but are they also passing stool through their stomach? Are they having a hard time passing stool? And really depending on where the stomach is, it's going to be dependent on the consistency of that stool. If it's in that ascending colon, it's going to be more liquidy, more watery, because it hasn't had a chance to fully absorb all those nutrients, all that fluid out of that stool. But if it's more toward that sigmoid colon, it's going to be closer to the consistency that normally comes out. So,
What about reuse of the bags for like your home health patient? I know that some of them are in that kind of situation. But
you can, if they're in that situation. It's not really a sterile procedure because it's stool. But we try and encourage them to not. But they only get limited amount of supplies, and insurance is only going to pay for a certain amount of bags. Maybe they had a real bad mishap somewhere and they had to throw away 2 or 3 bags. They couldn't get it to size appropriately. They couldn't get it to firmly seal appropriately. So they had to go through 3 or 4 bags, and now they're down to that 1 bag. So that can be something to consider as well. Any other thoughts on that? No? Okay. All right. Let's move on to breast cancer. Usually we're going to break down breast cancer into 2 different categories. So non-invasive or invasive. Non-invasive is going to really be contained within those mammary ducts or within that mammary tissue. Invasive is going to be within that mammary ducts, but also some of that surrounding tissue as well. We can also have breast cancer along around the nipple, and that's called Paget disease, P-A-G-E-T disease. And then we have triple negative breast cancer as well, where they don't express certain hormones. So that can develop as well. Definitely can occur in males. We have breast tissue as well. You don't think about that most of the time, but definitely can happen in males. Whole lot less common though. The staging and treatment plans are definitely going to be the same though, regardless of male and female. And then breast cancer is going to be that second leading cancer and cause of death among cancers behind lung cancer. So it's a pretty big deal.
So they have vaccines and like 2nd stage trials. It's like 100% effective for breast
I know
cancer.
it's some really good research that's been coming out here lately, treatment options. And to me, I feel like there's a cure out there somewhere. Just haven't found it yet.
I think they found it. They're choosing not to say that.
We won't get into that discussion tonight. But so signs and symptoms. What type of assessments findings do we need to talk about? Definitely need a good history first and foremost. There's a strong genetic component to breast cancer. And it really is not specific to any type of cancer. So if you have cancer in your family in general, whereas breast cancer or your father had testicular cancer, but there's a big, strong genetic component. I mentioned earlier the BCRA, the BRCA gene, 1 and 2, can be a big component or big factor in that. This is going to be a good slide for you to remember as well. Obesity is going to be a big component of it as well, and gender. So we need to talk to them about their mass, that lump, that area that they found while they were doing their self-breast exam. Or we found it upon doing that self-breast exam. I put a clock over here on the right side to remind us of how we're going to document or assess these masses. So we're definitely going to palpate like we did back in first semester, how we were doing the self-breast exams. I know that was a long time ago, like the first week of nursing school. But document the location. Where did we find it? Did we find it on the right breast, the left breast? Is there some type of landmark that we can use? Is it midline, or is it around the nipple? Or is it starting to get into the some of the lymph nodes within the upper arm? Shape and size. I've seen in documentation before saying golf ball size or softball size mass. You're not going to see something random though that no one knows. It's going to be general common stuff. I can't think of anything random, but nobody knows what a cricket ball is size. Okay, so you're not going to see that usually. But anyway, the consistency of the mass. So is it similar to the surrounding breast tissue. Younger females, it's going to be more of a firm, solid feel to the breast tissue, and then it's going to be even firmer nodular shape within that mass. As they grow older, women start to lose their muscle tone and their mass with air, and it's going to be more of a stringy, textured feel to it with age, and that's just due to that age. Other things to note: is there any kind of redness or hyperpigmentation, any kind of color change to one breast or the other? We have the peau d'orange, so it's going to have this orange pill shape or look to it. It's going to be kind of that firm, rigid, but have kind of like the porous look to the orange peel. We can have some nipple discharge as well, and definitely some pain and tenderness within that area. I highlighted box 62.1 as well, page 1521. Box 62.1, page 1521, for your signs and symptoms.
Can I just bring up two things?
Yeah, go for it, please.
So
I cannot speak a lot on this.
So I mentioned it earlier for like the BRCA testing and family history. I think this would be good to kind of like educate our patients on if they do have a strong family history.
Yep.
There's various different blood testing that you can do. I don't know about all of the companies, but we specifically go through Myriad. If you get the blood work, we'll go through Myriad. And a lot of people do have a strong family history of different kinds of cancers. For breast, we're specifically looking for breast cancer and cervical cancer. But Myriad tests for all kinds of cancers, and they tell you your risk about getting various different kinds of cancers. So if you have patients that have like a strong family history of cancer, I think that's something that would be good to educate them on getting done. And then for like the clock, we use the clock a lot. And then typically how we educate our patients for like self-examining is using like the middle of the clock as like the nipple and working our way out from one as a clock.
Yep.
And that's kind of like a good way to, if you are like a provider and you're setting in an order, they're also noting where it is, like at the 2 o'clock left outer position, approximately 4 centimeters from the nipple. But specifically for like the family history, I think that's always good to recommend genetic testing. That's something I recommend a lot for my patients, and we get a lot of like positive genetic results that they have like no symptoms or anything, but like a strong family history can lead to positive genetic results.
Yep.
And that's something that they can lead to monitoring for.
I like it. That's good. And that's something that's helpful with the blood test sometimes.
It is,
That's something we can definitely offer. There's all kind of genetic testing too that can be done for all different disorders or diseases as well. So, good stuff. Thank you. All right. How are we going to diagnose? Definitely going to get a biopsy of the tissue from that area, from that mass, to analyze it. We can look at it under a microscope, see if there's any type of cancer cell that's present. Why do I care about an AST and an ALT level? What does that level indicate? It's a what?
Liver enzyme.
Okay, it's liver enzymes. Why do I care about liver enzymes in breast cancer?
Because it determines when you start recycling your blood cells.
Maybe. What if it's metastasized to the liver? Are we going to have some changes? I'm going too far. Okay. Same with your calcium and your phosphate. We have metastasis to the bone. We can have elevated calcium and phosphate levels as well. We can further diagnose with a mammogram. The mammogram is really going to show us some type of mass or some type of pocket within the breast tissue. We can further analyze that area mass, that suspected area with an ultrasonograph as well. And that can really rule out if it's a fluid sac or maybe a cyst compared to other types of cancer cells. And then I looked at the MRI as well. That's not really a cost-efficient way. You're definitely not going to get insurance company to pay for MRI often. But if you're at a high risk and you need to get an MRI, then we can do that, and we can do them more often. It's just going to be a little more touchy on if we can get it approved.
Yeah, the breast MRIs are recommended for patients that do have that family history of breast cancer. We do a thing called Tyrer-Cuzick scoring, and that is your risk for breast cancer in your lifetime. And if you have a 20% or higher, then you're considered high risk. And most of the time, insurance companies will approve you to get a screening breast MRI.
Okay.
So most places will recommend you get a screening mammogram, and then 6 months later, you get a screening breast MRI. That way, every 6 months, you have some kind of screening of your breast tissue. So a lot of companies do approve breast MRIs if you do have that family history of breast cancer and are considered high risk.
There you go. Treatment wise. So again, I'm saying combination therapy over and over again, but that's what it's going to be. Mixed chemotherapy versus radiation. We hear a lot about the surgical side of it as well, a lumpectomy, where we take out just the lump or the mass itself, or we have the mastectomy, where we take the entire breast. But we got to think about the other side of it as well. How do we just treat our patient in general, so they can feel more like a human? So massage therapies, aromatherapies, acupuncture.
Is that more for pain?
Pain, it could be mentally as well. Stress reduction. It could almost be like a distraction type thing as well. Table 62.3, page 1523. It's going to show you some alternative treatments as well. I just listed a few here. But. All right, patient education. First and foremost, identify those risk factors. So increasing with age, there's definitely a strong genetic component. Early menarche, so do they have their menstrual cycle, start their menstrual cycle really early in age? Null parity, I'll just learn about that, but if they haven't had kids before. Of course, increased BMI, obesity. Did they go into menopause later in life? That's going to be another big one. Are they positive for those breast cancer genes? And if they've been on some type of hormone replacement, so it's increasing their hormones, can be another big risk factor. These risk factors can be very important, very, very important to educate our patients on so we can have early detection. All right, threefold method on our preventative screening. So we talked about the mammograms. We can also educate our patients on the importance or use of self-breast exams. Usually we're going to do it about a week or so after their period. We don't want to do it with on their period, and it's usually going to be once a month. Stephanie said the clock method for palpation. I always do the snake method. To me, I don't miss as much when I do the snake method. It's either way is great. So it's just whatever you prefer. And so you just kind of go in a snake-like pattern back and forth along the entire breast. You also want to educate them to go up into that upper arm region as well, because it can kind of spread up that way as well.
Can I put one last thing on
Yeah.
mammograms? So I've just been doing this for way too many years. If a patient has had a mom, like her mom was diagnosed with breast cancer at the age of 45, the only other thing that we would also recommend is that she go get annual screening mammograms 10 years prior to the mom's diagnosis. So typically we recommend screening mammograms for everybody at the age of 40, but if a mom was diagnosed at the age of 40, she'd go get her annual mammograms at the age of 30. Or if the mom was diagnosed at 45, the daughter would go get her mammograms at 35. So if the mom was diagnosed, young patient would start her mammograms 10 years prior. So that was another kind of
Took the words out of my mouth.
You had that, sorry.
No, you're good. You're good. You got way more experience with it than I do. So we're going to encourage those clinical breast exams as well. Just because they do self-breast exam doesn't mean that they're maybe not as thorough or they didn't feel something that we may have felt, vice versa. And then we're going to do those mammograms. So just kind of go back over what Stephanie said. If they are potentially at high risk, so they have a previous family history of breast cancer, we're going to start talking about those screenings around 40 to 45. And then even sooner, if they had a confirmed diagnosis, we need to definitely set 10 years prior to when they family member was diagnosed. Again, this is not specific to breast cancer, but it can be generalized for cancer in general. So if they have a strong history of cancer as a whole, definitely need to get them checked. We're going to start beginning those annual mammograms around 45. And then the book recommends after the age of 55, you can talk to your physician about it, and you can go to every 2 years if you need it. Okay. Yes?
Okay, so what if you had a patient whose like family member was an environmental case of cancer? Would you still go get checked regularly?
Yeah, I would.
Okay, thank you.
I don't think you have cancer though, Natalie.
Well, I'll look on there in 30
Okay.
years. 5 people in my family currently have it, so. I'm scared. Why has brain cancer?
Okay. So if they have a confirmed diagnosis and then we have a lumpectomy or a mastectomy, we're going to talk about our post-op care as well. Our big concerns with breast cancer recovery and after surgical recovery is going to be getting back to them to baseline as much as possible. Are they able to perform those ADLs as independently as possible? We're not trying to cause any strain or stress along those incision sites in that area, so we're not going to allow them to pick up heavy objects. If they were weightlifting or doing light exercise, maybe hold off on that. Mobility is going to be a big one as well. We don't want any contractures to develop, any decreased range of motion. We want to try to get them back to his baseline as much as possible. And then pain is also going to be a very big one for this as well. Of course, there's infection risk as well. Definitely want to have some mental health support on board. There's a lot of community resources out there as well. Which finding is most suggestive of an invasive type of breast cancer? A mobile, well-defined lump in the upper outer quadrants, redness and pure orange appearance over the breast, a bilateral nipple discharge without a mass, and non-palpable lesion found only on a mammogram. B. Good. Redness and that orange pill-like appearance. Nurses educating a group of patients about breast cancer prevention. Which of the following statements reflects a secondary prevention strategy? C. Good. Getting a routine mammogram helps detect breast cancer in its early stages. Remember, primary prevention is before the disease process starts. So we're preventing the disease from ever occurring. Secondary prevention is going to be more about screenings to catch the disease early if it occurs, so we can have early type of intervention. Cervical cancer. All right. So the cervix is going to be covered with a lot of squamous cells and columnar type cells. There's going to be frequent cellular division and frequent cellular growth. And that's usually where your cervical cancer is going to occur most often or start within that area. There is a lot of circulature as well in here, a lot of blood vessels in here, so it can metastasize pretty early, go to the surrounding lymph nodes and the surrounding organs within that area. That third bullet point's important as well. The HPV is going to be the most common type of STI, and that's really that biggest risk factor that they have identified in the development of cervical cancer. And so we'll talk about patient education-wise, what we need to tell our patients a little bit later. So we can have varying degrees of signs and symptoms with our cervical cancer. It's really going to start out with a little bit of vaginal bleeding. Might not have really any pain with that as well, and maybe just a little bit of bleeding after intercourse. And then it becomes more and more severe as we work our way up. So the advanced stages, we can even have stool within the vaginal cavity. We can be passing blood, just almost hemorrhaging amounts of blood, so an excessive amount of blood through the vaginal canal. We can begin to urinate blood. We can have blood in our stool. Have that right there. Severe amount of pelvic pain, back type pain, and that's going to be within those later stages of your cervical cancer. So definitely going to get some HPV testing if there is a chance or there has been some history where there could be suggestion for HPV. We definitely want to test for that because, again, that's going to be a great indicator of the potential to develop cervical cancer. We can also have what's called a colposcopy procedure. So they go in under ultrasound as they're doing a pap smear. They go in and put this type of acid along the cervix, and then they're able to look at it under magnification, and the cancer cells are going to react pretty severely to this type of acid that's being applied. The textbook said it was painless. I highly doubt that. It sounds pretty painful to me, but anyway. And then if they see any of those types of cells, again, they're going to take a biopsy. And that biopsy is going to confirm that cancer diagnosis for us. So we're going to have the non-surgical versus the surgical side. I mentioned brachytherapy earlier. That's for your prostate cancers, but we can also use it for our cervical cancer as well. That's where we have that internal therapy where we're able to place these little seed radiation type seeds along the cervix, and we're allowed to have just that slow, steady release of radiation to target that source. We can have that external beam radiation, so it's from that outside source. We're able to target the cervix directly to give them that radiation. Combination therapy again, so we can have a dose of that radiation versus the chemotherapy as well. And then on the surgical side, we have what's called a LEAP procedure. So the loop electrosurgical excision procedure. They have this really thin looking loop wire that they can place in there, and they can actually send kind of like an electrical current through that little wire, and it kind of cuts away some of that excess cervical tissue. And we can
Kind of like a TURP.
similar to a TURP. We'll talk about TURP in a little bit, but yeah, very similar. We're just trying to really slicing away real thin layers until we get all that excess tissue. The good thing with the loop procedure or the LEAP procedure here is that we can get a biopsy while we're doing this procedure itself. The laser surgery is a little bit less precise. We're just shooting a laser at the cervix, trying to burn away or cut away, destroy as much of that tumor, that cell growth as possible. With that, we can't get the biopsy, of course. We do cryosurgery as well, so we can freeze it as best we can. We have something called a radical tracheotomy. Here's my picture. So the radical tracheotomy, we're cutting away most of the cervix. We're also cutting part away of the vaginal canal and the surrounding tissues. We can get a lot of lymph nodes and stuff in this area, but we're taking away most of the cervix if we're trying to preserve fertility as much as possible. If they're wanting the ability to have children in the future, this is one procedure that we can have done to hopefully preserve that ability. Now, it's also going to increase our risk for preterm labor or having complications with having a child, because we are taking away that cervix. Right? That cervix is kind of the plug to allow for that full development or growth of that baby. And then we can have a full-on just hysterectomy. So we take everything out. We take the uterus out, cervix. You can also, sometimes they'll leave the ovaries. A lot of times they'll take the ovaries as well. What type of patient education do we need? Definitely talk to them about sexual health, protecting themselves. So anything that's related to sexual health. Multiple partners, definitely don't want that. If they do, then ways to protect themselves. We can discuss HPV vaccines. A big one that is the Gardasil 9 vaccination. That's really becoming popular these days. They're even starting to offer it to males as well, so they do not get HPV. There's not as much complications if males get HPV, but with the potential to spread it to others, we could definitely protect. We definitely want to encourage them to get their pap smear and their HPV testing. So when they go to their women's health visits, we can begin discussing that. So beginning at age 21 to roughly age 29, we're going to start testing every 3 years or so. Definitely going to do it more often if we're at a higher risk. So if we have a genetic component, that could be a good example. So we may do it more often than every 3 years. Starting at the age of 30 to roughly 65, definitely can do every 3 years for pap smear, and then we can start doing it every 5 years for your HPV testing, or you can have it all together every 5 years. And then greater than 65, that's kind of up to you, up to the patient, and then up to the healthcare provider as well. I know when I did my OB rotation, though, there was women in their 70s and 80s still getting them, just because that's what they've always done, and so they just felt like they needed to or had to. So. Okay. Definitely want to identify those risk type factors, the genetic component to it, the type of carcinogens, the HPV testing. And then we're going to talk to them about post-op type stuff. So anything related to cervical, so whether it be the hysterectomy or the tracheotomy, where they took out part of the cervix, we need to discuss sexual intercourse. So we need to refrain from that from a minimum of 2 weeks at least. No tampons or douches. We need to report any type of heavy drainage. So excess amount more than normal. So we can encourage them to use pads, things like that instead. Questions about cervical cancer? Anybody need a break or we keep going? Keep going? Yeah. Prostate cancer. So we talk about prostate. It's just this walnut-sized gland. I cannot talk today. Walnut-sized gland around the urethra and the bladder canal. Only men have it. I shouldn't have to say that, but I'm just going to throw that out there. I've had women say, my prostate's enlarged. Okay. This is a male gland. Okay. It's helpful in the management or production of sperm. It can also help in the production of different types of testosterone as well. Typically, we're going to see patients start out with BPH, or that benign prostatic hypertrophy, or just an enlarged prostate and overgrowth of the prostate gland, and then eventually will turn into that prostate cancer. Got to remember, it's all part of that cell regulation process, that overgrowth, that cell division occurring. Prostate's usually highly curable, highly treatable. It's real slow growing. We pretty much know where it's going to metastasize most of the time. Very strong genetic component again. I keep mentioning that and saying that. And it's definitely no matter the cancer either. So if your mother has breast cancer, definitely if your father has prostate cancer, but it could be a host of other types of cancers. Highly increased risk in African Americans as well. And they have more complications as well just due to the lack of access to care. Right. So signs and symptoms. Are they already being treated for BPH? That could be one of our big signs, early indicators. Maybe I need to watch this patient further for the development of prostate cancer. Are they having troubles with urination? So the more that prostate enlarges, the more that prostate grows, it's going to cause a lot of excess pressure along that bladder, the bladder neck, and down into the urethra. So they may have the urge to urinate more frequently, but they're unable to initiate that stream. They're not able to maintain the stream once they have it going. I always tell people it sounds like they're peeing in Morse code because it's a lot of starting and stopping. But they're going to have some type of troubles with urination. Eventually, it could lead to some sexual dysfunction as well. So some erectile dysfunction. Later stages, we're going to start to see it metastasize into other areas. So we're going to start to have some pain within the hips, the pelvis. They could potentially get into the liver, into the bone, within those lymph nodes. We're going to have some blood in the urine as well. And then I wrote digital rectal exam on here as well. And we're going to talk about that in the diagnosis plan. You will see some physicians that are still in old practice do digital rectal exams. It's really no longer indicated as best practice. It's more of just the PSA level, the prostate-specific antigen that they should be monitoring, but you will still see the digital rectal exams being performed. And so when they do the digital rectal exam, they're able to note the size, and that's how we're going to talk about the staging of our prostate cancer and our tumor growth. So if you look at table 64.3, page 1567, that's your prostate staging. So we're going to monitor their prostate levels, their PSA levels, and then we can also do the digital rectal exam as well. Normals, it's going to be about 2.4 or so. In African American males, it's going to be just a little bit higher. The higher the level of your PSA, the increased risk you have. Again, this is not specific to prostate cancer itself. It's something, an issue with the prostate. Yes.
Don't they need to draw for the PSA before they do a prostate exam?
Yes. So the PSA levels is really some type of stress along the prostate. So if you do a digital rectal exam, it can actually elevate your PSA levels before you draw it. If you have BPH, it can increase your PSA level. If you have prostate cancer. But we are going to monitor PSA level. The higher it is, the higher risk that you're going to have. So we have stage 1 of your prostate cancer. You're really not going to be able to palpate it or observe it on a digital rectal exam. So the physician's not going to be able to feel it when they go up in the rectum. PSA level is going to be roughly less than 10, but it's going to be a little bit higher. As we progress, of course, the prostate is going to enlarge, so we're going to be able to feel it. on our digital rectal exam, and our PSA level can get us even greater than 20. So it can be pretty significant. Funny story with the digital rectal exam. I had to do a bunch of those for my master's program, but every time they walked in the room and they thought they were a digital rectal exam, they thought it was with this small petite lady who had really small hands, and they made me do the digital rectal exam myself. My hands are a lot larger. The male was not appreciative that I was doing the exam instead of the little nurse practitioner that I was following. So, anyway. We can do an ultrasound as well. We go through the rectum and ultrasound that to see if there's an overgrowth of the prostate gland itself. We will eventually take a biopsy of that area to see if there's any presence of cancer cells within that area. And we can do some imaging as well. But the definitive diagnosis is going to be the biopsy. Somebody's angry. All right, let's talk about the non-surgical versus surgical side of treatment. The big one that I'm highlighting again is the brachytherapy. So that implantation of those low-dose radiation type seeds that can sit around or within that prostate, delivering that low dose of radiation. Again, that external beam radiation therapy. We can have the laparoscopic radical prostatectomy. So we're taking the bulk of the prostate. We can keep the perineal nerves around the rectum, around the bladder as well, intact when we did the laparoscopic radical prostatectomy. The TURP is basically just a resection or just a small section of the prostate, not curable in this. And then we can have what's called the open radical prostatectomy, and that's going to be for the most severe advanced forms of prostate cancer. So they're going to go in. They're actually going to take away all the prostate. They're actually going to cut away some of the bladder neck as well, and they're going to reattach the urethra to the bladder. So it's a pretty radical procedure, really invasive type of procedure. When they have that radical procedure, they're going to have a catheter for at least 1 to 2 weeks. You may see that three-way irrigation fully as well. A lot of y'all have seen that in clinical, where we're forcing a lot of fluids or flushing a lot of fluids through that catheter line to prevent clots from forming, to dilute that urine out so we don't have some type of obstruction from some type of clot. And it's going to be very physician specific. He's going to tell you, and he's going to give you instruction and orders on when to remove that Foley, how much fluid we need to filter through and flush out that urethra, things like that. With that radical prostatectomy as well, we can continue to have bladder issues. We can have incontinence type issues. It can also cause some sexual dysfunction as well because we're taking some of the seminal vesicles as well, so some of the sperm producing sites as well. And we can also, again, have that retrograde ejaculation as well, where the sperm backflows into that bladder. Okay. That's another picture of the brachytherapy. So we're using that ultrasound guided probe, insert it into the rectum there, and then we're taking a big giant needle and going up and placing those little seed implants within the prostate. Patient education. Need to talk to them about dietary health. So definitely going to decrease our animal fats, decrease a little bit of our dairy products as well. We want to encourage them to eat a lot of fruits and vegetables. We're going to talk to them about the necessary screenings they need. So when are we going to start those PSA screenings? If they're at a high risk, have that strong genetic component, already have BPH, have some of those other type of risk factors, we're going to start those PSA screenings at the age of 40. That moderate to high risk, we can start about the age of 45, and then that low risk will start at 55. Again, you are going to see the digital rectal exams in practice. It's no longer indicated, but you will see physicians still do that. We are not allowed to do digital rectal exams for prostate screenings. Okay, so don't go exploring. We're only allowed to do suppositories, things like that. We're not allowed to do the digital rectal exams. Okay. So please don't let me catch you doing that. Why you would do that, I don't know. It's strange.
Be good.
All right. Let's talk about lung cancer. We're almost there, guys, I promise. We're gonna classify it down into small cell lung cancer versus the non-small cell lung cancer. Lungs are very vasculature as well. There's a lot of blood supply to the lungs, so we are going to have some major metastasis as well to the surrounding lymph nodes. Of course, it can travel through the circulatory system to any part of the body as well. Our big things with this is going to be some type of inhalant of the carcinogen, whether that be cigarette smoke, asbestos, coal, even if it's not direct cigarette smoke, it's the secondhand smoke. The radon exposure, so it's a natural type gas that occurs, has no smell or odor to it. So radon exposure is a big one. I would definitely know my risk factors for lung cancer. Other warning signs on box 24.8, page 563. Second most common type of cancer, so you're going to see this pretty often. Depending on how big and the location of the tumor is really going to depend on what type of signs and symptoms that we see. Big one's going to be impaired gas exchange in the later stages. So what type of things would we assess if we see impaired gas exchange?
ABG.
ABGs, all right. Tell me about an ABG.
If they're having impaired gas exchange, you're pulling medical respiratory acidosis.
Respiratory acidosis, okay, good. So what does that mean to me?
They're not getting good option.
Okay, what are my numbers? What's my pH level?
7.35 or below.
Okay, good. What's my CO2 level?
Above 45.
Above 45, good. Bicarb doesn't really matter right now. So low pH, high CO2, we're going to be respiratory acidosis. What's some other assessments that we're going to see?
Pulmonary function test.
Pulmonary function test, yeah, we could do that. Be a decreased pulmonary function test.
SpO2.
Low SpO2, good. So maybe some cyanosis as well. What about clubbing of the fingers? You can probably see that, right? What about our lung sounds? What are they going to sound like? We could have some coarse bronchi. We could have some wheezing. What if I have a tumor that's pressing against my lung tissue and it's pushing against the pleural cavity? We're going to have a pleural rub. All right. Maybe some wheezing as well. Other things we can note, weight loss. They're working more on their breathing. It's causing them to overwork on their breathing, getting them to burn a lot of extra calories. Be very similar to like a COPD type patient, if you remember that from last semester. So that tactile fremitus, so you can feel some of those vibrations when they speak along their lower lobes of their chest. We can also have what's called absent breath sounds as well. So maybe they have a pneumothorax or a pleural effusion. So depending on where that is, over that side lobe area, we may not hear breath sounds at all. If we have an increased pneumothorax, maybe our trachea is deviated from midline. So you remember all those assessment tools way back when? All right, so how are we going to diagnose? Definitely going to get some type of biopsy at some point. We can also biopsy some of that pleural fluid that's within that pleural cavity. There is going to be some type of cancer cells floating around within that pleural fluid, that pleural space. Definitely going to get some imaging on board as well. Some type of MRI or PET scan. We can also do what's called a thoracoscopy as well. It's going to be this small, thin, flexible camera or scope. We're going to make a little incision within the chest cavity. We can actually insert that camera in there and kind of look around and see from there. This is a good example of a tumor within your chest X-ray right here. So you have some type of mass along my right upper lip. Okay. And then we'll see that extra bone. You can see the heart. You can see some of the gas exchange, the air that's in the lungs as well. You have that big, nice mass right there in the center. This is an X-ray of our pleural effusion. So you see here on the left side, the left lung is fully expanded further on down. We have our diaphragm right here at the bottom. We have the heart right here in the middle. On the left side, our lung is able to fully expand. Get that nice, good, deep breath of air, allowing for that gas exchange to occur. Right side, are we allowing that lung to fully expand? No, we're not. All right. So this is some type of fluid, just extra something that's taking up space right here. and that's something that we can have develop. My brother actually had one of these the other week. They took off 2 liters of fluid from his
That's a
lung.
lot.
It's a lot, yes. So
I'm sure he was showing some type of sign.
he was not.
No?
He seemed sick, right? Yeah. Okay. I don't know. My mom said he wasn't sick. But then he came in, he was super sick. I don't know.
Is it better?
He's better. He's fine now. So. He's back home in his underwear watching NASCAR. I guess he's okay. All right. Non-surgical side, have that combination therapy. We can have chemotherapy. We can have the radiation therapy as well. A big new one that's coming into play is that photodynamic therapy as well. So we actually infuse this type of agent, this chemical, this infusion into them, and it actually attracts to those cancer type cells. The cancer cells really like to absorb as much of this as possible. And then we can shine this photo light. So it's almost kind of like a red light, like a developing film, if you want to think about it that way. And it destroys those cancer cells specifically and not the other cells. Because that agent that we infuse doesn't like light. So it causes this chemical reaction to occur, killing off those cancer cells. So that's pretty cool. Other things, immunotherapy, allowing for that patient's immune system to work more efficiently, more aggressive, to really pick out those cancer type cells and kill off those cells that may otherwise not be detected. Depending on the staging and the grading of that tumor, we are going to consider surgical intervention. And how aggressive we're going to get with that surgical intervention is going to be dependent on that size. So we can either do what's called a lobectomy or a pneumonectomy. Lobectomy is going to take out a specific lobe or a piece or a lump or a piece of that tumor. The pneumonectomy is going to take out the whole lung itself. With this, we're going to have a lot of excess drainage. We're going to have some scarring. We can have definitely the possibility of developing a pneumo or some type of pleural effusion in addition to the tumor. So insertion of a chest tube is going to be big as well. And then we can also have what's called thoracentesis, and that's where just draining off that excess fluid around that pleural space. So I'll insert this really big catheter and just drain off that excess fluid. Y'all remember your chest tube education?
Mm-hmm.
What do we need to know about chest tubes, that kind of stuff? That's going to be very important. So you probably should know how to take care of a chest tube. All right, so what are some things that I need to know about chest tube?
Has to be below the chest level.
All right, below the chest level. I like it. What else?
Constant bubbling is bad.
Constant
Could
bubbling.
indicate a leak.
Okay, constant bubbling is bad or can indicate a leak. So we're going to have bubbling within our water seal chamber, right? The little blue section right here. All right. We can have some intermittent bubbling. That could be okay if there's a little bit of air and we're trying to reinflate that lung. We don't want constant continuous bubbling. We can also see some tiling occur. So usually the little white ball within this water seal chamber that is going to rise and fall with inspiration and expiration. That little orange accordion, we want that to be inflated, right? I always say dog in the window. Why? But the orange accordion has got to be within the window. That way I know that my suction is properly suctioned. If I don't have adequate suctioning, then you'll see partially open accordion or you won't see the accordion at all. We also have the negative suction pressure that's going to be set by the physician. We're not going to have to touch that ever again. And then we have our drainage chamber as well, depending on how much drainage we have. The bottom right over here is going to be what's actually inserted into the patient. What do I need to have at bedside for chest tube?
Sterile water.
Sterile water? Why?
Because it comes out.
Because it comes out, and then I can just put it back in there, right? Okay. What if it comes out all together?
You better
What else do I need?
tape it on 3 sides.
I need to have it all on 3 sides. Okay, so I need to have gauze, right?
Mm-hmm.
Gauze and tape.
Mm-hmm.
Tape it on 3 sides, allowing for some excess air to come out, but not, hopefully, air in. Hemostats as well, so I can clamp that chest tube if it's disconnected from the atrium itself. What if my patient suddenly starts complaining of shortness of breath? Maybe his trachea deviates to one side or the other. I look down at my chest tube. It's no longer draining like it usually was. What's some basic things that I can look at? Check the line. Like what? See if it's kinked or clamped, right?
Mm-hmm.
Maybe the nurse before me put the hemostats on and forgot about it. Maybe there's excessive looping or kinking of this tubing itself down here at the bottom, and it's not allowing for that suction to occur. All right. Everybody feel good about chest tubes? Let's see. I would know something about chest tubes. I would definitely know that. Patient education is going to be based on prevention strategies, your primary versus your secondary prevention strategies. So one big one is going to be reducing your exposure to tobacco, smoke, or to other pollutants within the air. So if you live in a big city, that could be some type of pollutant. If you're at a high risk, maybe you move further out so you're not exposed as much. Secondary prevention is going to be screening for types of lung cancer. If you're at a higher risk, they are going to start recommending you get a yearly CT scan or some type of yearly chest X-ray to screen for the potential to have a tumor develop. We're going to teach our patients about chest tube management. We're going to teach them some warning signs, things that they need to look out for, things that they need to call us to the room for. We're going to talk to them about shortness of breath. What does that mean to them? When do they need to come to the hospital? When do they need to come to ER? Infection risk is going to be big. Again, the development of a pneumothorax or pleural effusions can also be a big one. And what type of resources they have out there in the community. Patient has undergone a lobectomy for lung cancer, which post-operative nursing intervention is the main priority. Okay, so high-dose opioids for sedation. I don't really know if they're in pain. I don't really want to fully sedate them because that could cause increased risk for impaired gas exchange. So we'll knock that one out. The monitoring chest tube drainage and lung sounds. More than likely, they have some type of chest tubes. If not, I still definitely want to listen to lung sounds in case they develop a pneumothorax or some type of pleural effusion. Bed rest, not really matter one way or the other as much as they can tolerate. They want to get up and move it pretty quickly. And I'm not really going to restrict their fluids. So it'd be monitoring chest tube drainage and lung sounds. And then what patient is at the greatest risk for developing lung cancer?
See.
Good. 60-year-old with a 40-pack a year, smoking history, and exposure to asbestos.
He's probably smoking while he turned down the building.
Probably so. So remember, smoking, asbestos, coal, radon, those are important factors. Risk factors. All right. Leukemia. So the big thing with leukemia, this is going to be the blood cells, your white blood cells. It's going to be an overproduction of your white blood cells. Take a look at table 34.2, page 835. So your leukocytes, like I said, are your normal white blood cell production, just your normal overall everyday functioning. They are going to protect your immune system. They are your immune system to prevent some type of infection from occurring. Like I said, with leukemia, we have that excess or overgrowth of white blood cells. The key with this, yes, we may have elevated white blood cells, but they are immature white blood cells. They're not fully developed white blood cells. They're not able to fight off the infection as well. So it may look like we have a normal white blood cell count or even slightly elevated, but they're, for lack of a better term, useless to us. They're not able to fight off quite as well. We can also have some thrombocytopenia as well. We can also have a pancytopenia, like we talked about. The thrombocytopenia is your decreased platelet count. And we can have just overall anemia, so just a lower blood cell count in general. The system gets overwhelmed, and we have a decrease in function and leading to anemia. We can have acute versus chronic, and then we can have lymphoid versus myeloid type leukemias. With acute, they're not maturing whatsoever. With chronic, your white blood cells are going to mature some, they're just going to develop slightly. The lymphoid versus myeloid is the different pathways that it occurs or develops. Lymphocytic is going to be your white blood cell occurrence. Your myeloids is your RBCs. Right, your signs and symptoms. I would probably know this slide pretty good too. Most of the time, leukemia is going to be a real widespread, generalized type of signs and symptoms. You got to remember that they are anemic. So they have a low white blood cell count. They have low RBC count. They have a low platelet count. So that's why some of these things are going to develop. They're definitely going to be fatigued. They don't have adequate perfusion to carry out those daily functions. So they're going to be pretty tired. They're going to develop a petechiae type rash. So those small little red little blood vessels, you'll see those little red spots start to pop up because they don't have any platelets. So it's just almost this kind of little bruising appearance. They're also going to have some widespread bruising throughout. Their skin is going to be real pale. You'll even see the mucous membranes begin to be more pale. So we don't have adequate blood circulation throughout. There's really a high occurrence and a strong component with Down syndrome as well. And there's going to be an increase in your LDH, not your LDL, not with cholesterol, but your LDH, your lactate dehydrogenase. Increase lactate dehydrogenase. What are some other signs and symptoms of anemia in general? So that means there's going to be lead below volume altogether. So what's that going to mean for me? Weakness, okay.
Increased heart rate.
Increased heart rate, good. Okay. Dizziness, blood pressure is going to drop, right? Shortness of breath, good. So we're going to see some vital signs changes as well. Maybe our cap refill is greater than 3 seconds. Our main diagnosis is going to be a bone marrow aspiration, and we're going to do a biopsy of this as well. We're getting blood from the direct source from where they're made, and when we examine this under the microscope, we're going to see that we have a lot of immature white blood cells. Our platelets are going to be off as well, so we're not going to be able to clot. That's why we have that petechiae type rash. We have bruising throughout as well. And overall, just our blood levels are going to be off. So again, with that anemia. There is a lot on the slide, but we'll break it down. Number one goal is going to be infection prevention. Remember, our white blood cell count is off. Even if it's elevated or at normal level, they're immature and they're unable to fight off that infection properly as they should. So we need to educate our patients as well on infection prevention. Stay away from large crowds. Wash your hands frequently. Adequate hygiene. Wear a mask if necessary if you got to be in large crowds. We can give the tyrosine kinase inhibitors as well for the chronic myeloid leukemia. That's something that they're going to take pretty much forever, indefinitely. On the acute myeloid side, we have what's called induction and consolidation therapy as well. It's going to be a rapid and aggressive chemotherapy treatment for these patients. We're going to hit them hard to try to kill out or knock out as many of these immature white blood cells as possible. So it's a real rapid, fast treatment plan. They get diagnosed, they're going to start treatment probably that day. And that's hopefully what we're going to try to go for. And then moving on to the lymphatic side, we're going to try to do that induction therapy as well. But we're also going to use some other chemotherapy agents to kind of hit it from different angles. It's gotten into our central nervous system. We can also do some radiation therapy as well. And then we'll also put what's called methotrexate into that intrathecal area, so within that spinal column space. So this is going to be pretty aggressive forms of treatment as far as chemotherapy agents go. What you're looking at. We can also do stem cell transplant therapy as well to help build back up our immune system, to help build up the white blood cells, the red blood cells, and our platelet counts. Table 34.3, page 844, shows you the process of stem cells and stem cell transplantation. Stem cell transplantation can be really a touchy subject for some people because there's a lot of mixed reviews online through the news as well on how they obtain stem cells. So that has been a big issue in previous years. So we definitely need to educate our patients on how we obtain stem cells and the proper methods. There's a couple options. We can get it through cord blood as well. There's a lot of stem cells within that. So right after pregnancy, a lot of moms will donate the cord blood, and there's a lot of stem cells, good healthy stem cells that we can get from there. We can also do some bone aspirations as well. We can have some bone marrow transplants and get some of those stem cells out of there. Once we recover those, we're going to do that induction therapy first with the patients. So we're going to do that aggressive chemotherapy, radiation therapy at first to try to kill off as many of those immature white blood cells as we can, or the other immature cells. Once we destroy that as much as possible and they're back into what we call remission, then we can initiate the transplantation process. So we'll actually give them back the stem cells. At this point, we've pretty much knocked out their immune system because we have driven their blood count levels so far down, trying to get them into remission. They're going to be at the greatest risk right now for infection. So that's going to be education-wise. We need to educate them on infection prevention here. As the stem cells begin to grow, they begin to mature. That's when we will start to see our white blood cells, our RBCs, our platelets begin to come back up. So we'll start to get frequent lab checks, and hopefully we will see kind of return back to baseline of our blood counts. So patient education-wise, we need to discuss health promotion, so good heart healthy diet, adequate exercise, disease-type preventions, stay away from large crowds, like I said before, so it's going to move into our infection prevention. Vaccinations, that's after they go into recovery, okay? You can also discuss with them vaccinations, but that's going to be a physician call on whether they get vaccinations during treatment. And that's also going to be dependent on if it's a live vaccine versus a dead vaccine. For this aggressive type of chemotherapy that we are going to give our patients, they are more than likely going to have some type of central line in place. Whether it be a subclavian port, maybe they have an IJ central line, or they have a PIC. More than likely, it's going to be a port that's going to be long-term that stays with them. So we need to talk to them about patient safety, patient education-wise on central line care. They're not going to be accessing their ports. That's going to be some type of home health nurse, or they're going to go into an infusion-type clinic or a cancer-type clinic that's going to access their port for them. But they need to know a day or two after to monitor for drainage, monitor for infection risk, maybe some type of reaction to the chemo drugs. Definitely want to always keep that site as clean as possible. So talk to them about hygiene. Are they able to have home health, or do they have other support that can come over and help them take care of this central line? And then just additional community resources. Okay. Questions about leukemia? Okay.